Welcome to EMSYM 2024. Competence at the doorstep, actions that matter.
Good morning, everyone. Distinguished guests, esteemed colleagues, and dear friends. It gives us immense pleasure to welcome you all to EMSYM 2024. This event brings together the brightest minds in the field of emergency medicine, as well as many experts from other specialties to share knowledge and envision the future of emergency healthcare.
In today's rapidly evolving healthcare landscape, the role of emergency medicine has become increasingly critical. As frontline providers, we face complex challenges daily, requiring us to stay updated with the latest advancements in diagnosis, treatment, and patient care.
Before the commencement of proceedings, we would like to remind few housekeeping rules as well. Please keep your phone silent throughout the sessions and do not disturb others. And also, washrooms are located at the main entrance of the lobby. And also, in case of fire emergency, fire exits are located at the both sides of the hall. So keep those few housekeeping rules also in your mind. To begin today's proceedings, ladies and gentlemen, let us welcome our esteemed chief guest, Dr. Ananda Vijay Wickrama, President of the Sri Lanka Medical Association, who is here to grace this occasion with his presence. Sir, we are honored and privileged to have you here with us today to herald this event.
Now, let us come together in a moment with pride and unity. Ladies and gentlemen, let us now rise for the national anthem. May I kindly request the audience to remain standing as we proceed to light the ceremonial oil lamp, a symbol of knowledge, wisdom, and enlightenment. May I now invite the following dignitaries to grace this auspicious occasion. Dr. Ananda Vijay Wickrama, our honorable chief guest. Dr. Inuka Wijegunawardana, President, Sri Lanka College of Emergency Physicians. Dr. Indeka de Lanerolle, Chairperson, Specialty Board in Emergency Medicine. Dr. Nadaraja Prasanna, Secretary, Sri Lanka College of Emergency Physicians. Dr. Dushyantha Goonewardene, Academic Secretary, Sri Lanka College of Emergency Physicians, and Chief Organizer of EMSYM 2024. Dr. Chamindra Samaraveera, Co-Organizer, EMSYM 2024. Dr. Dilshan Priyankara, Consultant Intensivist, National Hospital of Sri Lanka. Representing the organizing committee, Dr. Nisanki Vithana, Dr. Asanka Saparamadu, Dr. Methmal Malavarati. Thank you very much. You may now return to your seats.
Now I cordially invite Dr. Inuka Wijegunawardana, President of Sri Lanka College of Emergency Physicians, to deliver the welcome note. Over to you, sir.
Good morning, ladies and gentlemen. It is my honor or privilege to welcome you all EMSYM 2024, the academic activities brought by Sri Lanka College of Emergency Physicians. Let me thank our esteemed chief guest, Dr. Ananda Wijegunawardana, senior clinical physician, and she's president of Sri Lanka Medical Association. Welcome you, sir, for this event. You are very enlightening, your presence of this event. And also, I include my deepest gratitude to all organizing, distinguished organizing committee to brought this through. And also, include my deepest gratitude to distinguished speakers and participants and dear sponsors. And thank you and wish you and a fruitful and exit session discussion hereafter. Thank you. We are starting the session.
Let us now begin with the first plenary for today. Emergency medicine is the heartbeat of healthcare, where every second matters and every decision can change a life. It is a field defined by urgency, resilience, and unwavering commitment to patients in their most vulnerable moments. To guide us through this journey, we are fortunate to have the first emergency consultant in Sri Lanka, Dr. Inuka de Lanerolle. As he takes us through the cognition of complex decision-making in emergency department, ladies and gentlemen, please put your hands together and give a warm welcome to Dr. Inuka de Lanerolle.
Good morning, Dr. Ananda Wijegunawardana, our esteemed chief guest, dear sir, my dear colleagues. When I was asked to do this topic, I was in a bit of a dilemma. I really did not understand what the topic is. It looks more psychological than emergency medicine, I guess. So then I think I have a duty to justify the topic. I think this gentleman is familiar, Steve Waugh, a very ardent, esteemed captain of Australian Test cricket, a very successful person. At his retirement, he said this: in high-performance settings, success is 20%. Success is 20% skill and 80% mental resilience. I think that gives a justification. And this was quoted by many in many other fields after this. So during this 15 minutes, I'm going to talk about this 80%. And unfortunately or fortunately for you, you will be spending your next 6 hours here discussing about the other 20%. So I think this is important, so please listen. The entire talk revolves around this question. Have you ever had to make a decision in seconds, knowing it could save or cost a life, have a legal repercussions, and unfortunately be criticized by others? Welcome to the emergency department. And that's our daily life. And if you go through a normal emergency department in other countries, it has different areas. Research area where you have category 1 and 2s, acute areas we got category 2s and 3s, and subacute areas where you got category 3s and 4s. So in a normal day, this may be the case. In a research area, you may be having a 45-year-old person with an inferior STEMI, with a complete heart block, and he has a past history of ICH, so you can't thrombolize him. Unfortunately, cardiologist says they cannot offer a PCI. So this may be one patient. At the same time, you may be having a 16-year-old DKA, drowsy, losing the airway. You know that the DKA, we don't jump and intubate. You need to make a decision. And in the acute area, you've got a 35-year-old person having status, and he's an IVD on top of that. And another patient, a 70-year-old, a CT confirmed ICH, and this poor fellow is telling that I need to go home, and he's fighting with your staff. In the subacute area, you've got a simple cellulitis, and you give an antibiotics, and he's now developing anaphylaxis. I can go on forth. But in another one, a 27-year-old with a headache, you think it's a migraine, but then you develop a non-blanching rash. You know the non-blanching rash, what is the problem? A meningococcal sepsis need to be in mind. So all these patients need your personal attention at times, at one given time. And our system is so kind. On top of that, these things happen. Limited resources, the sister comes and says, the minor staff is not there, you don't have ambulances, and the patient transport an issue. Isn't it our normal day sometimes? So when this happens, and this is how it is. This is how it is. Our head is not in one place. So that begs the question, what makes the decision making in ED is unique? All decisions are unique. What makes ED is unique? That's because all these problems are there. It's a very high pressure, time constraint, time critical management should be done in most patients. And you don't have lots of information. High degree of uncertainty is there. Information is always incomplete. And you got many patients. You cannot control the inflow. You basically cannot control the inflow. And you got all these resource limitations. You need to multitask, just like the examples that I said you. You cannot stay with one patient. And there are lots of emotional, psychological, ethical issues. And as a result, you are prone to bias. The bias is a different entity in normal day-to-day life, but that is a different entity when it comes to the ED. So, coming back to the first question, have you ever had to make a decision in seconds, knowing it could lead to all these problems? This is what we need to do. So when I was going through literature, I found these two books, an excellent read. Right? So, starting with that, these books talk about how a normal brain would make decisions under pressure, not only in ED, but in any other place. So they talk about two systems, a system 1 and system 2. So system 1 is fast, subconscious, automatic. You just do subconscious mind, you do quick decisions. And system 2 is slow pace, conscious, effortful, and you make complex decisions. So a question to audience, what do you think is best suited for the emergency department? Is it system 1 or is it system 2? I think most of us will think maybe system 1, but in reality, the system 1 and system 2 should go hand in hand, right? Over-reliance of one system, for example, system 1 can lead to bias, and over-reliance of system 2 lead to slow decision making. So in the ED, unless you strike a balance, you cannot function as a very good emergency physician. Then the next thing that which I need to talk about, what is this bias? The bias in normal colloquial language is that you are taking a partial decision, a decision which is partial towards some person or party. So what is this bias in ED? They talk about so many types of bias, about 10, 15 types they describe. I'll take one or two examples, clinical cases, the real day life clinical cases which I have encountered, and try to describe what this bias is. Take this patient. A 45-year-old male who comes with chest pain. He got a costochondral tenderness, and you diagnose musculoskeletal chest pain, common diagnosis, right? And one of your junior doctors come and say, doctor, there's a slight ECG change. For example, say AVLT inversion may be the first ECG change that can happen in inferior STEMI, or suckle, something like an Chulanga pattern. But you disregard it. So finally, it becomes an inferior STEMI. So you make a wrong decision, overconfidence bias, a superiority complex, right? Where you are overly confident in your diagnosis and you do not think of other possibilities. You disregard the other ideas. The second one, what about this? A 40-year-old male coming with multiple episodes of vomiting and there's ECG inversions and you diagnose ACS. No other cardiac risk factors. You start antiplatelets and patients say, I cannot walk. This actually ended up in having posterior circulation stroke. Right. So that's another type of bias, which is called confirmatory bias. You think of a wrong diagnosis and you try to gather information to confirm that, disregarding others. Then this one, a 55-year-old male presented with acute shortness of breath, with low oxygen saturation, and he's complaining of chest discomfort. And he has a history of COPD. So what's our diagnosis generally is a COPD exacerbation. Maybe infective, maybe non-infective, right? But later, a chest X-ray reviewed a right-sided pneumothorax. Now that is another type of a cognitive bias, which is called availability bias. Making decisions based on readily available information, like the patient was having COPD. So I, based on this shortness of breath, on readily available information, which is a COPD exacerbation, right? But finally, I did not think of a less common presentation, which is right-sided pneumothorax. It looks simple here, but when it's a pressure cooker environment, these bias can occur because these are all real-life case scenarios. Right. So far, we discussed briefly, though, what makes ED decisions unique and challenging. And then we briefly touch upon how does the brain make decisions under pressure, the system 1 and system 2 correlation. Then we discuss about a decision bias, which might lead into wrong decision, which might cost a life. But next few slides is about how to overcome these problems. You might think, okay, there's nothing to talk, but these are the real 6 things that they talk about. How to improve your decision making. First one, you may need to maintain situational awareness. Ar Buduhamduru can samma satiya. That's what it says. Right? You need to have a mental picture of your emergency department. You need to know about the patients, right? Which patient needs your personal attention. You need to know about the environment. You need to know about your team. For example, when the ED has a difficult, a bad, crashing patient, you probably, as the team leader, won't go and treat that patient. You get a person who is equally capable, who has the necessary skill set, and delegate that patient to him and only helps, and you look after the ED. That's called maintaining situational awareness. The second one, we use a lot of cognitive tools. Right? People think the emergency medicine is inferior because you use simple tools, but these cognitive tools are important. We use checklists. For example, an intubation checklist. We intubate a crashing patient with a rapid sequence induction, delayed sequence induction, or modified rapid sequence induction. Right? You try to intubate and you are looking for the suction catheter. That is not good. So we look and we use checklist. And you use a lot of mnemonics. under pressure, you can't be thinking of lots of diagnosis sometimes. So you need to think of simple things and the diagnosis which cannot be missed. And we use these mnemonics, for example, headaches, SNOOP, which has been devised by the American Headache Association. That gives a bit of a quality to that mnemonic, isn't it, when it comes to the American. But we use these things. Back pain, a common mnemonic is a tuna fish. And we use what we call debiasing techniques. It is always good when things are going wrong and when not going wrong. Pause, stop, take a step back and think, am I going right? Is there any other possibility? Talk to people. There's no harm. Talk to people. They will give a different perspective. Ego should not crash there. Just talk to people. Teamwork and communication. I don't need to talk a lot about this because there are so many speakers who will speak about teamwork and communication. But just think about a CPR session in your unit or in your ward. Are we really doing it the way that it should be done and it should be described? Think about it. The next one is reflective learning and continuous education. Continuous education we are doing, reflective learning. Not many people do understand what is reflective learning. It is something sometimes when you do right or sometimes when you do wrong, you go and read. If you have done something wrong, try to find out what's the best way to make it correct. And if you have done something right sometimes, how to improve it. That's called reflective learning. So you need to practice that. Finally, your well-being. You need to be strong in mind and physically. So these 6 qualities are essential when it comes to the ED. This is an excellent podcast if anyone is interested. Please listen to him. Once a week he gives a podcast where they talk about mental resilience. It's good in day-to-day life also. So finally, this is my last slide. ED demands quick thinking under pressure. And sometimes you look stupid and you look, still you are human. So you need to have a way of solving this problem. So then we discuss about how the brain reacts in a normal pressure cooker environment. And we discuss about bias in the ED, 3 types of bias with 3 different examples. And the final thing we discuss is how to arrive at a correct diagnosis. Thank you very much. And I should be personally thanking Doctors Lakita and Dr. Samoda for helping me. Thank you so much.
Thank you, sir, for such an interesting and insightful presentation. This will indeed help us make better decisions in the emergency department in future. It is with great enthusiasm we now move on to our next plenary session on dengue emergencies, a topic of great significance that continues to shape the healthcare landscape of our country in profound ways. Despite how far we have come in understanding and managing this deadly illness, it still continues to take a significant number of lives every year. Let's warmly welcome our distinguished chief guest, Dr. Ananda Wijewikrama, to share with us the latest insights in this important topic. Dr. Ananda Wijewikrama is a household name in the medical profession and needs no special introduction. He is currently a senior consultant physician at the National Institute of Infectious Diseases, Colombo, and is also the current president of the Sri Lanka Medical Association. I wouldn't be wrong if I say he is the foremost expert in dengue management in Sri Lanka, thus making him the best person to deliver this plenary. We are indeed lucky to have him with us to share his knowledge with us. Over to you, sir.
Thank you very much for the kind introduction. First, I would like to thank the President and the organizing committee for inviting me first as the chief guest, and also to give this for giving this opportunity to talk about this topic. First, I would like to say, going with the Indika's talk, to manage dengue, we don't need a lot of facilities. So in that sense, in whatever the setup we are having, we should be able to manage dengue patient and also even a patient in dengue shock syndrome. So as it was said, it's not an uncommon presentation. Over the years, we were able to reduce the mortality rate in Sri Lanka due to dengue significantly, very significantly. And however, still we get a lot of patients. And when we go through some of the deaths, we find that some still could have been prevented. And in such instance, the emergency department plays an important role. Let's look at this history of this patient. This is an actual patient, 25-year-old male coming with a fever for 5 days with nausea and vomiting, dizziness, reduced output. So you know when a patient comes with complaining of patient with fever coming with complaining of dizziness and reduced urine output, that means it's a problem. And in Sri Lanka, in the present context, we have to consider dengue. Now this patient had come to the OPD on day 3 of fever and had a blood count done, which showed a platelet count of 138,000. He was not admitted for some reason, and he was sent home asking him to get another blood count done on day 4. So he came back on day 4, gave a sample, waited for 1 hour, and was told that the sample was clotted. So he went home. Still, he had, even then he had dizziness, though the OPD doctors probably did not pay attention. So when he got admitted on day 5, this was his situation. He was in shock. In the OPD, blood pressure was 70/60, and then he was admitted to our ETU. This patient came to my hospital. And in the ETU, blood pressure was 100/80. The difference, as you know, is due to the change of posture. And he was tachycardic, prolonged CRFT, so he was in prolonged shock. So in a situation like this, especially with the previous count available, we have to strongly suspect dengue. Of course, it could be something else also, but the initial management will not be much of a difference. So the clinical diagnosis in such setting would be dengue shock syndrome. Now this is a slide which was shown to us by Thai experts when we were trained many years ago by Thai experts. In dengue, if the shock is prolonged, if it is more than 10 hours, they say whatever you do after that, the patient dies. And if they are untreated for 4 hours, they will go into acute liver injury, and half of them can die. Our rates are much better now, but this was the situation 15 years ago. And 3-organ failure, they said the survival is a miracle. Occasionally we were able to achieve this miracle, but this is difficult. So let's see, why do they develop shock in dengue? Now this is obviously due to significant loss of intravascular volume, either due to plasma leakage or due to bleeding, which is often occult, and commonly due to both. And of course, other fluid losses like vomiting, loose motion can contribute. So therefore, replenishing the intravascular volume is the key method of treatment, and it's not inotropes. So in the management, we recommend to put 2 IV cannulae and urgent PCV. We have to do inward PCVs. We can't wait for the blood counts to come. So having a microhematocrit machine, which is not an expensive gadget, and also the test is also very low cost. So it's important to have it in the emergency department, any emergency department. And then we give a rapid fluid bolus, and of course oxygen, and monitor vital signs. And in such a patient, since they are likely to bleed, if not they are bleeding already, the blood should be sent for grouping and DT, and then doing VBG, liver function test. Those are important. Generally, we give calcium for these shock patients. So in this patient, the hematocrit was 55. Now, when you consider normal hematocrit, you see there is a significant increase in hematocrit, and of course in this patient the initial hematocrit was, I think it was 40 or something. So these are very significant rise in the hematocrit, indicating that there is significant plasma leakage. And when you got the blood count, it was 20,000. So after the first bolus, so we assume that the patient has leaked for at least 24 hours or maybe more even. And after 1 hour, that is after the first bolus, the hematocrit has come down to 32. And the other parameters are now improving. Blood pressure has now improved to 110/80. So then for the next hour, the fluid was slightly reduced. And now the patient is improving. So this is how the fluid was given. If the patient comes early in shock, generally after a first bolus, they improve. Clinically, they improve fully, but we should not cut down the fluid immediately or rapidly. We have to gradually reduce the fluid because the leaking tend to continue. Otherwise, if you reduce the fluid immediately or cut down it rapidly, the patient can go into shock again within few hours. An initial resuscitation should be with crystalloids. Now, this patient, after about 15 hours, again became unstable with rising PCV, and then we gave him a dextran. And with that, the patient became stable, so we cut down the fluid further. And after that, the patient, no further interventions are necessary. So you can see how easy to diagnose this patient if the correct, how easy to manage this patient if the correct diagnosis was made. So early diagnosis is very important, and early resuscitation is very important. So in this patient, the pitfalls, the patient was not admitted even when the count was low, and they were not, the sample was clotted, so the patient was either should have been asked to do another blood count, or the patient should have been admitted. On the other hand, when the patient was admitted, the shock was identified, bolus was given, then it was the gradual reduction of fluid, and patient was monitored closely, and later dextran was given. So the key points in resuscitation is that the initial resuscitation should be with the crystalloids, the gradual reduction of fluid, colloid later if necessary, and consider blood if the patient is unstable with dropping hematocrit. So this is the fluid resuscitation regime we use. We gradually reduce the fluid, and the algorithm, this in guidelines. So basically, if the patient is unstable, we give bolus depending on the crystalloid bolus, then depending on the improvement, we decide with the improvement of the clinical parameters, and we make a decision based on the hematocrit also. If there's a rapid drop of hematocrit, one has to suspect bleeding and should give blood early. So if they don't respond well to initial fluid resuscitation, we have to suspect acidosis, bleeding, calcium, and sugar, which needs to be corrected. One problem we see, not only in Sri Lanka, in other parts of the world also, is the difficulty in diagnosing bleeding. Now this is the Scott Halstead. He's the, I would consider he the best person in the managing dengue, and who has given a lot of recommendations based on various, based on his evidence. This is what he said: severe but occult bleeding can be difficult to recognize. These patients exhibit severe hemodynamic instability, but with a relatively normal hematocrit compared to those with only plasma leakage. So in plasma leakage, the hematocrit obviously goes up. Many patients with severe bleeding have initial or ongoing plasma leakage that keeps the HCT in the normal range despite the severe bleed. So this is something which we have to recognize, because as said here, bleeding in dengue is often occult. Now this is a patient whom we had a couple of years back, who needed 5 units of blood for us to make him stable. You can see the bleeding into the thickened swollen psoas muscle to which the bleeding has occurred compared with the previous one. Now this will be a better slide. This patient needed 6 units of blood. You can see the thickened rectus muscle, which you can see better in this slide. You can compare with the normal right-sided rectus muscle and the thickened rectus muscle on the left side, to which the bleeding has occurred. There was no other bleeding. So bleeding was into this, and we had to give 6 units to make this patient stable. But of course, you can't do CT scans in everybody, and it's not necessary either. So that's why we have to go by the clinical parameters and the hematocrit. So the indications we use to give transfusions are if there's overbleeding, if they have more than 250, 300 ml, we give blood. And then if there's a significant drop of hematocrit in an unstable patient, or hypertensive patient with normal hematocrit or low hematocrit, and worsening metabolic acidosis, refractory shock. And also you need to consider blood transfusion if the patient is in shock with a small amount of plasma leakage. You do a scan, there's not much of rise of hematocrit, and the scan doesn't show a lot of fluid. So we know the intravascular volume depletion has to be due to bleeding, though it is not obvious. And if the patient is in shock in acidosis, in these conditions we have to consider giving blood. We have to have a low threshold of giving blood, and then you see low or normal hematocrit with unstable parameters. Let's look at another patient. This patient, of course, had presented many years ago, but still this will give us an indication of what can happen to these patients. Now, this patient was admitted. This is based on the presentation made by another unit. I have just extracted the necessary things. I haven't made any changes. This is a 29-year-old male admitted in the night with vomiting and abdominal pain. He had fever for 2 days, but his complaint was abdominal pain, and because of the abdominal pain, he had been admitted to the surgical casualty unit. And in the surgical casualty unit, the history taken by the house officer, fever for 2 days, no chills, fever free for 1 day, and he had vomiting, regurgitation, output is okay, and not exposed to mud. And he was ill-looking, blanching skin, reduced air entry, tachycardia, is in shock, blood pressure is 800/80, erect not recordable, coated tongue, petechiae plus, tender right hypochondrium. All these are in favor of dengue shock syndrome. So they made the diagnosis and wrote to medicine registrar, casualty medical unit, dear colleague, 29-year-old patient is admitted with epigastric pain. He gives a history of fever for 2 days with vomiting and regurgitation. On examination, he has narrow pulse pressure with petechial rash and hepatomegaly. There's right pleural effusion, and he has significant severe hemoconcentration with thrombocytopenia. And so after 2.5 hours after admission, he was admitted to the medical ward. And in the medical ward, the house officer writes, again flushed, the blood pressure was 96, blood pressure 90/70, and so he suspects dengue and suggests to give initial bolus and fluid, oral 50 and IV 50. So the registrar sees at the same time, diagnosed dengue shock syndrome, CRFT more than 2 seconds, blood pressure 90/70 supine, erect unrecordable, and recommend to give normal saline over 500 over 30 minutes, and then repeat the PCV, monitor the patient, preserve platelet. If the parameters not improving, go for colloid bolus. At 1 p.m., 1 a.m. rather, patient still in shock after the fluid bolus, given dextran, and post-colloid blood pressure is 100/80. PCV 54. You can see the degree of hemoconcentration. And in next morning, liver enzymes have gone up. They were talking about dengue hepatitis. This slide made by and the PCV is 57. So what has happened was, he was given a fluid bolus at the beginning, given dextran 350 after that, and then as prescribed by the house officer, he was given fluid oral 50 and IV 50. And in the morning, 11 hours later, he had 600 given over 7 hours, 500 ml, and the initial boluses. So you saw that after the first crystalloid bolus, he was still in shock. After the second, after the dextran bolus, pressure has improved, but still the patient was in shock. And then after that, patient was given fluid at a flat rate. And then the patient's liver enzymes have derailed due to acute liver injury. It's not hepatitis, it's due to acute liver injury. And now the patient had been in shock. So you can see what sort of problems can occur because of the abdominal pain. Patient was admitted to the surgical ward. The surgical ward people diagnosed dengue shock syndrome, but unfortunately they didn't resuscitate the patient. So we lost valuable 2 hours. And then after resuscitation, immediately after the first 2 hours, the fluid was cut down immediately. So the patient continued to be in shock till morning. And then after that, they started giving liver failure regime and various things. And the scan shows plasma leakage. And in spite of these things, the patient died. So identifying shock is very important. The pulse pressure is narrow, perfusion of vital organs is impaired, and unlike in other shocks, most other shocks, the acute liver injury sets in very early in dengue shock syndrome. And if it goes beyond a certain period, then patient becomes irrecoverable. So that is the main issue in this thing. We can treat renal failure in leptospirosis, we can treat shock due to myocardial infarction, provided some tissue remains. But here, if the liver damage goes beyond a certain extent, then we can't save these patients. So therefore, identifying shock early and treating it is very important. So for this is the identification of plasma leakage, identification of bleeding, and it is the anticipation. And for this, we have to use parameters, settling of fever, platelet count going below 100,000, rise of PCV, and change of vital parameters, and ultrasound stimulation. Now here again, I want to stress one thing. Don't rely entirely on ultrasound scan or the electronic monitors. It is very important to touch these patients, feel the pulse, not only the pulse rate, the pulse volume, the peripheries, whether they are cold, clammy, or sweaty. So these findings are very important in identifying the shock. And then the complaints about the postural dizziness, postural blood pressure drop. So these clinical parameters are very important. Simple clinical parameters are very important in managing these patients. And the early identification and regular monitoring, PCV measurement, and as I said, the touching patients. So the common mistakes we see is not getting full blood count quickly, you don't think of dengue sometimes, and not doing regular PCVs. This happens commonly in the ward, and not monitoring regularly, and then too much of dependency on electronic monitoring and ultrasound findings, ignoring abnormal findings because other findings are okay, so the output is okay, so you're not worried about other hematocrit rise. And then sometimes diagnosing rare conditions like hepatic encephalopathy in liver due to primary injury and so on. And giving fluid at a flat rate is one of the common problems, and not giving blood and not thinking of blood is the problem we see often. So the unusual manifestations in dengue is unusual. The common reason for death is the prolonged shock and the bleeding, and majority are due to that. And often these patients come late, and then you have the problem in managing these patients in the emergency department. So immediate resuscitation of shock is very important, and monitoring hematocrit and the hemodynamic parameters and taking decisions based on these is very important. Thank you.
Ladies and gentlemen, what an enriching session we've just experienced. Thank you, sir, for enlightening us with your expertise. I kindly request you to remain on stage, and may I call upon the previous speaker, Dr. Inuka Lanerolle, back on stage. I also invite Dr. Inuka Wijegunawardana, President of Sri Lanka College of Emergency Physicians, to present the tokens of appreciations to these respected speakers. Thank you, gentlemen. Let's give a big round of applause to our incredible speakers for their inspiring contributions today. Ladies and gentlemen, that concludes our first 2 plenary sessions for the day. We will now take a short break for tea. Tea will be served at 5 stations in the lobby just outside the hall. As we have a fantastic lineup ahead for you, I humbly request you to return to your seats promptly at 9:15 a.m. Thank you.
Attention everyone, please be seated. We are going to start the next symposium soon.
Now, it's time to move on to the first symposium of the day, from Wheeze to Vent. This session promises to take you on an insightful journey through some critical moments of a very common respiratory emergency we encounter every day. This symposium features a distinguished panel of speakers, each of who bring invaluable expertise and experience from each of their specialties.
Let me introduce the panel of speakers. Who better to discuss Wheeze than a member of the committee who developed the guideline for the management of asthma for the Ceylon College of Physicians. Dr. Aflah Sadikeen, Consultant Respiratory Physician, National Hospital of Sri Lanka. Sir, can you please come up on stage? Dr. Dilshan Priyankara. This young, charismatic gentleman is a consultant intensivist at the National Hospital of Sri Lanka and the founder-president of the Ceylon College of Critical Care Specialists. Our third panelist for this symposium, Dr. Dushyantha Goonewardana, Consultant Emergency Physician, Colombo South Teaching Hospital. He is the Academic Secretary for the Sri Lanka College of Emergency Physicians and is the innovator and chief organizer of EMSYM 2024. And the final panelist, Dr. Kaminda Wijenayaka, our dynamic consultant emergency physician from the base hospital, Homagama, and also the treasurer of Sri Lanka College of Emergency Physicians.
Guiding the first symposium, we have Dr. Lakitha Veeratunga and Dr. Sanuri Pandikorala, Senior Registrars of Emergency Medicine. So, without much further ado, let's move on to the first session. Over to you, Dr. Lakitha and Dr. Sanuri.
Within a few hours, you'll get Kiela.
Good morning, everyone. I warmly welcome you to the first symposium of the day. So we have with us a very expert panel, so I'm sure that this discussion would be very informative and very engaging. So I'm Dr. Sanuri and this is Lakitha. So Lakitha will be starting with the first case discussion, case scenario of the day.
Good morning. So this is a real life case which came to NHS
Computer meeting.
Okay, so this is a 45-year-old gentleman who presented to ED with the worsening shortness of breath and chest tightness for 3 hours. He could not speak in sentences, and the wife says that he is complaining that he is about to die. And he has a non-productive cough, worse at night. He doesn't have any fever. He didn't have any exertional chest pain. He didn't have any orthopnea, PND, suggestive of heart failure or angina. No history of allergies. And he says he's a social smoker. And he used inhalers, not properly followed up, but inhaler salbutamol MDI on and off for 5 years, which he said he get this shortness of breath regularly, but he responds to salbutamol, but today it didn't respond. So these are the vitals of the patient. So airway is patent, and the respirator is dyspneic, very dyspneic, saturation 91 on room air, no deviation of trachea, bilateral symmetrical chest expansion, And percussion note is equally resonant, and bilateral reduced breath sounds with some bronchi. Heart rate is around 122, blood pressure is 130 and 80, and capillary time is 2 seconds. He's alert, and blood sugar is 223, and temperature is 36.5. So you can imagine the case, like he's a very dysmic man coming with cesarean. So to start the proceeding, so can I ask Dr. Dushyantha, sir, can you explain the key areas to evaluate this patient? So this is asthma, the patient coming with wheezing.
Right. So this gentleman has presented with he's on inhalers, so that suggestive of asthma. The fact that he is dyspneic, tachypneic, he's unable to speak in a complete sentence, and he's desaturating. We have to this will have to be taken as an acute exacerbation, a severe exacerbation of bronchial asthma. So immediately, patient should be taken to the resuscitation area, and we start the treatment protocol immediately. So prop them up, put them on oxygen, high flow oxygen, and start our nebulization back to back. And get a peripheral 2 IV accesses in and start the steroids and take the blood for basic investigations, which including a blood gas. At the same time, we would have to think of the other potential differential diagnosis that we may need to consider, which could be cardiac asthma or heart failure, or whether it's a lower respiratory tract infection, a pneumonia, which is complicating exacerbation. So that would be my initial thoughts at the presentation.
Thank you, sir. So my question is to Dr. Aflah Sadikeen. Sir, in your opinion, is this adult onset asthma or is this COPD? And is it important to differentiate the two?
First of all, I want to thank the College of Emergency Medicine for giving me this opportunity. Now, emergency setup, it's always more than looking at the bottom of the course at the outset. We are always compelled to stabilize the patient and manage immediately. So in that context, whether this is going to be asthma or COPD, thinking of that may not be appropriate at the outset. However, we have to keep it in our mind to know whether there is a difference between COPD and asthma for an emergency management, is whether it's important or not, number one. Why it is important? Not only in the emergency situation, also in long term to improve the quality of life, to reduce the morbidity and mortality. And why? Though we know that asthma and COPD has a different pathophysiology. So both involve inflammation and bronchoconstriction. Now, it is always important to have a good history, as any other medical condition, to differentiate these two conditions. As I said before, it is important for the management to know whether this is asthma exacerbation or COPD exacerbation. So the history will guide us what kind of a condition we are managing now. Now, a person, like in this case, he is on salbutamol, that is a rescue. So a short-acting beta-2 agonist inhaler. So he has been on for quite a few years. So there had been no previous evaluation, there had been no previous investigations or previous record for us to confirm our diagnosis, whether this is an asthma which has been there before and now it is coming with an exacerbation. On the other hand, if we are thinking of COPD, we may not have a clear-cut exposure to smoking or fumes or occupational exposure or any previous diagnosis of COPD for us to think about on managing. Now, why it is important, since I told previously I told you it is a two different or distinct pathophysiological process. In asthma, yes, there is an inflammation going on, but in addition to that, the inflammatory process with bronchoconstriction is also quite important. But in COPD, yes, there is an inflammatory process going on, there is a bronchoconstriction going on, but it is important to identify most of these exacerbations or the acute presentation is of an infective origin. There are situations, there are non-infective exacerbation as well. So it is important for you to know whether this is asthma or COPD to think about. Now, for us, why on management, I'll proceed from the next, when we go through along the case, whether there's any difference in this situation. So bottom line is, yes, it is important. And whether this is early onset asthma or late onset asthma, adult onset asthma is not something we are concerned about now.
Thank you, sir.
Thank you very much for that insightful answer, sir. So as Dr. Dushyantha said, we have done a ABG, some other investigation, ECG is normal, so this is the ABG. So next question is to Dr. Kaminda. What do you think about this blood gas and the importance of doing a blood gas on asthma patient?
Okay, so if you ask about the blood gas, yes, without the patient factor, I would say this is bad. Right, so you are lucky to have a ABG at the admission. In most of the EDs we don't have, and we are not doing so much of investigation unless patient is critically ill, like in this case scenario. So if we consider as this blood gas, ABG, my main worry is the oxygenation. I hope, as Dr. Dushyantha mentioned, now patient is on at least proper position with 50 liters of non-rebreathing face mask, and the US bronchodilators are going on now. Because that oxygen is 60, oxygenation is 71, it is not that adequate. Patient is inadequately, oxygenation is there. And then my worry is is acidotic. It is mixed acidosis. It shows the evidence of metabolic as well as the respiratory acidosis. As we all know, even the normal carbon dioxide level, PCO2, is bad in asthma. Now you are giving to me PCO2 of 70, that is too bad then. And on top of that, lactase is 4.1, that means the patient is having tissue hypoxia. So if I interpret this without the patient, this is a bad ABG, but we are not treating numbers, we are treating to the patient. So it all depends, the timing of the ABG. If you are taking this patient ABG at the beginning of your treatment, if the patient is responding to your bronchodilators and second line therapies and invasive, non-invasive, whatever the treatment you are going to give, you are fine. Don't worry about these numbers because we are treating to the patient, not to the numbers. But if you are taking this ABG in the middle of your treatment, once you started your bronchodilators, NIVs, invasive, whatever, but now we are failing our treatment. So your take-home message is this ABG is having the evidence of type 2 or the hypercapnic respiratory failure with metabolic and respiratory acidosis with true hypoxia. And you ask another question, is it important to have ABGs? Yes, at the beginning as a baseline level, you can have some other evidence like potassium levels, because we are going to pump with salbutamol for these patients, so it influx your potassiums into the cell. It's important to have the baseline potassium level when you are managing the asthma patients with a lot of bronchodilators. So I agree, and as well as you can assess your response of this patient when you are managing asthma patient. When you are giving the invasive or the non-invasive management, it's important to have the baseline ABG.
Thank you, sir. The next question is also directed to Dr. Kaminda Wijenayaka. So, sir, in this case scenario, how do you sort of decide on the initial treatment for a patient like this?
Yeah, so initially, I think Dr. Dushyantha touched on that a little bit. First of all, we have to comfort the patient with the positioning, and you have to start what they say. It's even you don't have a saturation approach, just start on oxygen, because oxygen itself is a bronchodilator. So you're going to start on oxygen with the non-rebreathing face mask, and you are going to start bronchodilators, which is commonly used, the salbutamol, as well as you can combine with the ipratropium. So we are going to do the intermittent or the back-to-back nebulization is the matter. According to the GINA guidelines 2024, what they say is, in the case of acute severe exacerbation of bronchial asthma, always go for a continuous or the back-to-back nebulization. And according to the BTS guidelines, what they say is, if you are failing the intermittent nebulization, go for a continuous or the back-to-back nebulization. But bottom line is basically in the case of acute severe exacerbation of bronchial asthma, go for a continuous or back-to-back nebulization with bronchodilators, and it will improve your lung functions as well as it will improve your symptoms.
Thank you, sir.
Thank you. So before I go ahead with the treatment and all, I need to ask one question from Dr. Dushyantha. Are there any other bedside tests that we can do in this kind of patient?
Yes. So bedside ultrasound focus will help to differentiate some of the other differentials that you need to entertain. Basically, whether there is the presence of or absence of lung sliding or a lung point, which is a pneumothorax. Then the presence of a B profile, which would signify fluid overload heart failure. So that would be one of the things, in addition to the arterial blood gas, point of care ultrasound would be useful. At the same time, in the Western world, we do the peak flow assessment, but in Sri Lanka, it's not really practical to do the peak flow at the bedside. So that would be the two investigations I would consider at this point.
One more question from Dr. Aflah Sadikeen. Sir, what's the place of this, the Dr. Dushyantha said about peak expiratory flow rate. So what's the place in ED to use in peak expiratory flow rate?
I think it's very important to have that knowledge that the peak expiratory flow rate measurements in exacerbation of asthma is important in mild exacerbation and to mild to moderate. But there is no place for you to have an assessment on the severe exacerbation which may be life-threatening. So we should not talk about it. As an example, in this case, we should not talk about it. So why it is important for you to know about it is because most of those patients who are coming to exacerbation with exacerbations, they are excited and they are panic. Those patients are with shortness of breath. We all know that symptom of acute shortness of breath coming, and they are little, I mean, they are what they call, they have that feeling that this is a life-threatening situation. Yes, fair enough, because we really don't know when they come to you. But when an ED doctor examine, or he's taken history and examine, they are in a position to tell, no, this is not a life-threatening situation. This is not an acute severe asthma which is needing, blood gas and some kind of intervention, including high flow or NIV or anything. This is just an exacerbation. This can be a mild exacerbation. So what you need, a simple nebulization. But how do you say that with confidence that this patient is having mild exacerbation? Of course, if you have a peak flow meter, then that will give you. So you can't just jump into peak flow meter thinking this patient is having mild asthma. So for you to have a previous records, have I done the diagnosis of asthma? Has this patient has an asthma diagnosis in the past? In that context, what were the previous exacerbation? With all those, as an example, if this patient had a previous exacerbation in an ICU care. So this may look like a mild exacerbation, mild to moderate exacerbation. But if your peak flow reading, which is recorded previously, will tell you this time peak flow reading is really worrying for you to, intensify your management. So you have to understand having a peak flow reading is important on those patients who are mild to moderate, not in a acute setup.
Can I add to that?
Yes, sure.
Can you go back to the blood gas, please? So, now this is the first blood gas on arrival. Now, the asthma is classically a type 1 failure. If you see this blood gas as the first blood gas, I would be worried. One thing, why his CO2 is so high. It's not just pure and simple asthma. Is there an underlying some other pathology, like what he said, a pneumothorax, or maybe a pneumonia even? And because he's maybe presenting for the first time, is it? I don't know.
Yeah.
So, and he has a mixed acidosis here. So if it is just now the question came whether it's a COPD or asthma, is it important differentiation? Now this patient If you're a COPD, yes, there's a definite place for a NIV. You start medication, but it's going to progress. So you are looking at the backup of NIV in this patient if it's a classic COPD. So I'm worried why the CO2 is high in this patient if you are thinking of an asthma. Second thing, if you look at the bicarb, it's 18. So there's a metabolic component also. So if you have a double burden on the chest of this patient, he's struggling to breathe. On top of that, he has a metabolic acidosis which he has to compensate from the respiration. So you need not only to address the respiration, you have to address the metabolic acidosis as well at the same time. Otherwise, the patient get exhausted, and you see the CO2 may go up, and the bicarb will go down.
Thank you, sir. So, yes, next we have done back-to-back nebulization with salbutamol. We have started normal saline, and we have given hydrocortisone 100 milligram. So my next question is about the steroids from Dr. Aflah Sadikeen, sir. So what steroid when you want to give IV? The people give methylprednisolone, dexamethasone, and hydrocortisone.
Right. First, we'll talk about the patient before we get the. So in this patient, like we heard from the previous speakers, that acutely ill, and probably there is a chance of impending respiratory arrest, and patient is unable to communicate, talk, maybe unable to swallow, right? So definitely we know steroids is going to help. In this situation, this patient needs some IV steroids. So when we give IV steroids, the recommendation, which is very important for us to understand, the recommendation is for IV hydrocortisone in some papers. However, if you look at the guidelines, they always talk about a standard management with steroids, that is with oral prednisolone. Now remember, all those randomized controlled trials and the papers for steroids were mainly done with COPD. So in that context, oral prednisolone is the one which is recommended. So they give high dose, that means maybe up to 40 to 45 milligram, and oral. But in this patient, we have no choice. Sometimes it is quite difficult and to struggle with so many tablets. So giving IV hydrocortisone is the right choice. Now the next question comes, yes, if you are giving steroids, if we have evidence, so what are the evidence we have for asthma? Yes, asthma steroids, there are some papers, and the recommendation is also based on those papers, because it bring down the inflammation, and also in long term there is a benefit of preventing or minimizing the future exacerbations. That is clearly indicated, clearly postulated. Now, if it comes for COPD, it is quite extensive that the use of steroids in exacerbation has improved the FE1 in long term. So it's a good thing. And second thing also, it brings down the inflammation, and exacerbations, future exacerbations also reducing. So also in COPD patients, use of steroids in short term will improve the mortality. So that there's another paper on that as well. So lot of evidence for COPD exacerbation. For asthma, yes, it is very useful, but not so many papers or evidence like in, but again those RCTs and meta-analysis again done with COPD. Now the next question comes, which steroid we are going to use. So now the recommendation for prednisolone. So IV hydrocortisone, yes, in a situation like this. Then the next option comes, can't we use IV methylprednisolone if it is so. But again, there is no large studies have done to the use of IV methylprednisolone. Use of IV methylprednisolone in severe exacerbation, especially again with COPD, it's done, there are some papers to show, but it is not superior. It is not superior. And the next question comes about dexamethasone. So this is another hot thing came up some time back, and there were few papers came up especially for small children. Why? It is a long-acting one and quite potent if you look at, compare with the oral prednisolone. Now, they say that maybe a oral single dose, in those papers they said, single dose or even 3-day short courses of small children, yes, there is a benefit in mild to moderate acute asthma. Not again in acute severe asthma, probably life-threatening in situations, no, there is no evidence. So bottom line is, yes, steroid is very important, especially in COPD for mortality benefit. And if you take in asthma, yes, it will bring down the inflammation quite quickly, and also it is important to reduce the future exacerbation.
Thank you, sir. So in this patient, are there any features that would suggest that the patient is having a steroid-resistant asthma or a eosinophilic phenotype of asthma?
Now, again, remember, we are in the emergency setup. So to differentiate whether this is steroid sensitive or steroid resistant, steroid sensitive, or some people say there's one phenotype is eosinophilic asthma, and the steroid resistant, they say that is the one phenotype is coming from neutrophilic asthma. So it may not be able to differentiate at the outset, number one. Number two, in an emergency, differentiating that is not going to give you any benefit. Because anyway, we have to give steroids to bring down the inflammation. Because when we say steroid resistant, there is no resistance as such, zero. So why we talk about in neutrophilic, some certain the phenotype in neutrophilic asthma, why the steroid may not use, may not be very effective as in the another group of the eosinophilic phenotype, because there is the number of receptors they can in those patients are down, and steroid receptors, and there is an alternative pathway for signaling in those patients. That's why their steroid response is not so great. So you have to use steroids, having at the outset, knowing about whether this is neutrophilic or eosinophilic is not going to help you.
Thank you, sir. So now we move on in the case scenario. So we are 40 minutes into the management of this patient, and still there is very little progress. The patient is still in severe respiratory distress, with patient is still tachypneic. Saturation is only 94 with 50 liters of oxygen, and there's tachycardia going on as well. So my next question is to Dr. Wijegunawardana. So what does the evidence suggest about escalating treatment in a patient like this?
Right. So now we have tried the initial thing and that doesn't seem to be working, so we need to go to our second line, which will be the IV drugs. So in most guidelines we talk about magnesium sulfate. So mag sulfate has moved up the scale now as the first line IV agent that we use in BTS and in most other guidelines. So a bolus of mag sulfate, 1.2 to 2 grams, would be indicated at this point. So mag sulfate will improve the FEV1, it will reduce the hospital stay, and there is a thing to say that it reduces the mortality as well, morbidity. So start with magnesium. In the United States and those countries, they do consider giving multiple boluses of mag sulfate and maybe going up to the level of mag sulfate infusion. Then after that, if mag sulfate is not working, then the next thing we could consider starting IV salbutamol. Again, the cost is the issue. So probably a bolus of salbutamol, 15 mics per kg, and then followed by a salbutamol infusion will need to be piggyback onto the mag sulfate. And of course, there is the next thing thought about in this country, we consider using aminophylline. That is still lower down in the list. So first mag sulfate, next salbutamol. Thirdly, I would consider aminophylline, the bolus plus the infusion. In addition to that, historically, adrenaline was used before salbutamol was available. So people used to give IM adrenaline, and sometimes places subcut cutaneous adrenaline plus adrenaline infusion. So there are certain trials that have shown that adrenaline is effective because it has a bronchodilatory action, but of course it has its other side effects like tachycardia and those problems. And of course, now increasingly, we might have to consider ketamine, which is coming back into favor. So certain people would benefit by probably a bolus of ketamine, say 0.5 milligram per kg, and we might consider a ketamine infusion depending on the circumstance when you need to buy time.
Thank you, sir.
Can I just interrupt? So what is the place for repeating the max sulfate?
Yeah.
And are there any evidence we have that max sulfate nebulization in these situations?
Yeah, so BTS talks about max sulfate nebulization for kids, right? In the pediatric population where they say add max sulfate nebulization. But it doesn't talk about adult nebulization with max sulf. But in practice, max sulfate works when you give nebulization. So sometimes some people who are really deteriorating, you nebulize them with max sulfate and you turn them around. But there is really no trials to say that max sulfate really works at that point. And again, now in the US, they do try giving multiple doses of max sulfate with the hope that it will settle. And probably it can prevent an intubation as the patient deteriorates further.
Thank you.
So, like now this patient is not responding to initial therapy and the IV drugs and even magnesium sulfate. Dr. Kaminda, sir, is this can be what you call asthma mimic? Can we differentiate in asthma mimics at this stage? How to differentiate?
Yes, it's a very important question actually. That is how the emergency physician's mind works, as Dr. Lanerolle mentioned earlier. So you have to think about we are failing, now what else it could be. So as we discussed previously also, it can be something else. So can it be allergic or the anaphylaxis? Are we missing anaphylaxis here? Because that also give rise to bronchospasms. So in that case, again, as Dr. Sadikeen correctly mentioned, the history and the proper examination, looking for evidence of any rashes or any allergen exposures play a very important role in that case, because the treatment may be completely different on that case, but still you have to give the bronchodilators here. And then, can it be early COPD? I think Dr. Sadikeen is correctly informed. It doesn't matter, the initial management is going to be the same. And it is basically again the history and the pack years of cigarettes and the progression of the disease and everything come into play. It is basically history. And can it be heart failure? And Dr. Dushyantha mentioned. So yes, we can do it. We can identify the heart failure at the bedside. It's again the history, orthopnea, and then the clinical findings of the bilateral leg swellings, JVP elevation, and the crackles all over the lungs, along with the B lines in the point of care ultrasound at the bedside. So can it be PE? Even though we are not talking pulmonary embolism in the context of wheezing, it says, the guideline says 1 out of 10 people can have wheezing because of their reactions to the emboli in the case of pulmonary embolism. So it is basically going through the Wells score, Wells criteria, and see whether this patient is in high risk of having pulmonary embolism. So it can be the foreign body, in the case of children, and in the case of the mentally retarded patients, it can be foreign. In that case, you are getting the unilateral wheezing. So, and can it be drug induced? Yes, of course. There's it can be due to the ACE inhibitors. It can be due to the beta blockers, and what you are giving, and it can be aspirin on the non-steroidal anti-inflammatory drug induced wheezing. In that case, it's a chronic thing, and again, the history will give you a clue. And then, can be due to something else in the upper airways. It can be an obstruction due to the lymph node enlargement, or maybe cancers. We can compress your trachea, give you the polyphonic wheezing. It is rare, but it's still possible. Right, and then can it be higher up in the vocal cords? Yes, that's also possible, but in that case, usually as per you're getting the expiratory wheezing, it can be inspiratory wheezing also. If the vocal cords are paradoximal mood against your breathing due to vocal cord dysfunction, yes, that can also give rise to a wheezing. So there are so many differential diagnoses. Usually the asthma respond to your bronchodilators, but this is not that case, that we have to think about other differential diagnoses before we move on, and you have to use bedside investigation and your history and examination skills to determine whether this is anything else.
Thank you, sir. So now we have started a bolus of mag sulfate, and after the bolus, still the patient is in severe respiratory distress, and we have decided to escalate the treatment to NIV. So my question is to Dr. Dilshan Priyankara, sir, what is the role of an NIV, that is non-invasive ventilation, in managing asthma-related respiratory failure?
So if you talk about NIV, and if this is a classic COPD, yes, I would definitely start NIV. The question is there a place for NIV in asthma exacerbations? Because we are driven by the evidence. So if there's evidence, yes, we'll do, because there are definite evidence for COPD which reduce the intubation rates and reduce the mortality rates. But that has not been proven in asthmatics. But some would argue why, if that works for COPD, why this doesn't work for asthmatics. So if the basic pathophysiology is different in the lung mechanics, so that may be a reason that the NIV is not beneficial as the COPDs where the NIV doesn't work. But is there a place? There might be a place. But for example, if you want to transfer this patient to ICU before, if you don't you want to intubate, if you want to transfer to ICU, or if you want to buy time for intubation, yes. So there might be a place. But if you put a patient on an NIV, in an asthmatic, the thing that you have to monitor is the respiratory rate. Whether it comes down, it's static, or it's getting worse. Because you can't put a NIV and relax like a COPD, you think he's going to get better, because patient might crash at one point. If you are jolly well, you think it's going to improve with the NIV. So you have to keep that in your mind.
Yes, sir. Thank you, sir. So what is the place for high flow nasal oxygen, and what's the evidence regarding this?
So now, asthma is a classic type 1 respiratory failure. So if you tell high flow, yes, that should work. So there is some evidence that the high flow would improve the oxygenation, and especially with the high flow, that the nebulized drugs would act better than the normal face mask oxygenation, and also it gives some humidification where rather than the drying the air. So that has some benefits to improve oxygenation, but has never been proven that it reduces your intubation rates and your mortality.
Right.
If I just add to Dilshan's thing, quite correctly he said about this NIV. And for high flow, to add, there had been some papers and studies. Now, of course, low recommendation, use of high flow in small children. So the success rate to avoid intubation, there are some papers use of high flow in small children. But again, in both when you are using high flow and NIV in asthma exacerbation, acute severe exacerbation, the most important thing is the monitoring, and basically we are, like he said, buying time for intubation. So if we can't monitor, we should not try.
Right. Thank you, sir. So there are various types of NIV. So what is the initial setting? Is it BiPAP or CPAP that you would start in this patient?
No, I mean, looking at the respiratory acidosis, definitely their problem would be, most of the asthmatics, their oxygenation, if you see, they're usually good.
Right.
But in this patient, I said non-rebreather mask, so I would, and a raised CO2, so probably bi-level ventilation or BiPAP would be better option if you really trying to apply NIV on this patient.
Thank you. Are there any contraindications for NIV in a patient like this?
So I mean, generally speaking, any contraindication that for NIV would apply here, like obtunded patient who's going down and who had a lot of secretions, you can't put it out, and your hemodynamics are crashing, then probably, because they're not proven in these situations, why do you apply such a thing who is has some conditions that are going to fail with NIV.
Right.
So 30 minutes into NIV, the patient is still in distress. Maybe the distress is worsened. We have worrying sign like saturation still 90. Respiratory is actually gone down. and now the patient is agitated and removes face mask and is sweating profusely. The next question is Dr. Kaminda. So what's next now?
Yes, as Dr. Dilshan correctly mentioned, now we are going down the track. You say that the respiratory was like 40s, now it's coming down to 22. That doesn't mean that patient is improving. You can see the saturation despite of oxygen is going down now, heart rate is rising, and the patient's blood pressure also crashing. Now we are dealing with the crashing patients, even though you can't buy time with NIVs now. Even though we don't like to intubate asthma patients in emergency department, now you end up with no choice situation. Patient is removing your face mask and he's sweating profusely, now he's crashing. Of course, I agree, even though we don't like to intubate this patient because we are thinking of dynamic inflations and whether we are going to worse this acidosis and lot of side effects of intubation of bronchial asthma, and we know, and also on top of that, we know that this is not going to help with the asthma management. We have to get rid of this bronchospasm, and the inflammation is not going to help with the intubation because we are going to increase the airway resistance further by putting a tube in. So even though with that those considerations also in this kind of case, now we don't have any other choice. We have to go for a intubation and thinking that patient is having not enough ability to maintain his work of breathing, and patient's work of breathing going down now.
We are a bit of running out of time, so I'll move through the case. So Dr. Dilshan, can you explain that what is your approach to like pre-oxygenation and intubating this rapid sequence induction and all in this patient? What are your thoughts?
So intubation itself in an asthmatic is a question. Now, it's a clinical decision because now you are going to, the thing that you are going to do should improve his outcome or his parameters. And the problem with the asthmatics, if you are asking for trouble, sometimes if you put a tube in, because then you find all the problems that you can't ventilate this patient, sometimes then you intubate. So it's a clinical decision, but your maximal pharmacological therapy is not responding, he is getting obtunded, his GC is going down, so whatever your brief NIV is not working, yes. So there's no other way that you have to, put a tube in. So pre-oxygenation, either your face mask, nasal high flow would be a very good option in intubating. And also sometimes you can bridge with an NIV if you really think that your intubation, it's going to be a crashing intubation. So pre-oxygenation wise that, and also the position of these patients, you keep the patient the most comfortable position for the patient at first. And when you give your sedatives, then you get him down, and at the appropriate position you get the laryngoscope in. And also you have to have the backup of difficult airways, and also keep in mind that these patients are really dehydrated, so get some IV fluid running in these patients because the blood pressure can crash, especially when they have the air trapping and dynamic hyperinflation comes in. When you put them on sedatives, their blood pressure gonna crash and sometimes might end up in the cardiac arrest.
Yes,
and also, when you're putting a tube in, get the appropriate size of the tube, because we have seen patients who have an airway resistance come with a very small size tube. So that adds to the resistance.
Thank you, sir.
If I ask you, what are the most significant challenges when you're intubating and managing? Because usually we need to, once intubated in the ED, we usually need to keep for 2 hours to MICU get to bed to get ready. That's very common, it's the usual thing. So what are the challenges that you encounter and how to navigate that?
We ask the ETU guys not to intubate, send the patient to the ICU, we'll intubate. No, if it takes time, yes, so as moment you intubate, you see the challenges. It comes up with difficulty in ventilation. Most of the guys, if you don't have a florid pneumonia or something, their oxygenation is fairly okay. You can rapidly come down on your F5 dose, but problem comes, getting rid of the carbon dioxide, the respiratory acidosis. So that's the main challenge, and with that you get the hemodynamic compromise because of rise in intrathoracic pressures and the air trapping and the dynamic hyperinflation. So those are the challenges I'm going to face. And also with sometimes when the patients are really tachypnic and struggling, you might have problems with sedation as well. So initially you get them deeply sedated and get good control of the ventilation, and then see how the blood gases work. Now, what I want to tell is that the intubation itself not going to cure. So what you have to treat the asthma. So sometimes you might have to back to back. Now you have done the nebulization. Sometimes you might have to retry nebulizing them again, because the intubation itself is not going to cure what's going in the lungs. It's just a support.
How do you try, what are the, you know about the high PEEP and low PEEP, high airway pressures, how to navigate, how do?
So people looked at various different modes, what mode we can try, but there's no difference in any of the mode if you know how, what you're going to expect. So this is one of our patients who came to our ICU. If you see that the peak airway pressure is 63, if you see his heat ratios is 1:18 that we have to put to get rid of the carbon dioxide. So this is one problem that you see. So high peak airway pressures, that's basically due to resistance, because if you see the plateau pressure, that the pressure at the end of the inspiration is 15. So your plateau pressure is something coming from the alveoli, where if you take the peak airway pressure, so the plateau plus the resistance will alter the peak airway pressures. So I'm not worried about the barotrauma or volutrauma, because your plateau pressures are low. So I need to get this volume into this patient and also get the carbon dioxide out. So what I will do, what the recommendation is, give more time for the expiration. So you may need a higher or longer expiratory time compared to inspiration. When you lower the inspiratory time, the flow will be faster. So you get a higher flow and short inspiratory time and a long expiratory time. That is the key. If you want to get that, you need to reduce the respiratory rate. You can't get a respirator of 24 with that IE ratio. So to lower the respiratory rate and acceptable minute ventilation. So if you see this type classic flow time graph that you see, no expiratory limb at all. See, and I have kept the PEEP at 0. Now in asthmatics, even though there's not much of an evidence, you go for a lower PEEP, or maybe even to 0. But in COPDs, you might get a slightly higher PEEP and a moderate sort of 6 to 8 ml of kg tidal volumes, and I kept the respirator at 16. So if you know their peak airway pressures, and if you put 400, if the peak airway pressure is high, so this is the volume control. So the machine will limit by its alarm. So you have to go up on the pressure alarms if we are on the volume control, or if you can put them on pressure regulated volume control. You regulate the pressure according to the lung mechanics and deliver the tidal volume. So that's a real challenge. That we had one patient, we had to increase the peak air pressure up to 100 to get that volume in, and his CO2 was 180. So I was basically about to refer the patient to the ECMO, but patient gradually responded.
Thank you, sir. So we have come to the end of the Symposium 1. So I thank all our esteemed panelists for giving such valuable information with your experience. So I hope you all learned everything.
We can take 1 or 2 questions from the audience. There's one.
Good morning to everyone. What is the place and evidence for the nebulization with adrenaline, especially a case like pediatric patients comes with ETU with the acute SOB, is there any evidence? Because the acute setup, pediatric, we hardly challenging to take a history. So even from the mother, even from the patients, is there any particular evidence?
There are some papers, but no recommendation. It's very, very clear. And there is not in the guidelines. However, we all know that in a desperate situation, we are forced to do first certain things. But does not mean that we should take that into grant to, that you can use adrenaline. So on certain people with their experience, they have used in pediatric population, but definitely not in adult population. I personally feel it should not be encouraged and recommended.
Thank you, sir.
We have a set of enthusiastic participants joining via Zoom. So we have got few questions from them. I think we have addressed some of the questions already. So I would like to combine both questions at once from our esteemed panelists. I would like to ask, in a patient with an acute exacerbation of asthma with CO2 retention, is there an indication to use BiPAP? And the other question is, what would be the best oxygenation therapy in asthma patients? I think both questions can be already addressed and can give a short answer for that.
Yeah, so best oxygenation would be you try your high flow and your nebulization with oxygen-driven nebulization. And in this setup, in this scenario, because there's carbon dioxide retention, BiPAP would be the modality you would be going for till you buy time for intubation, right? So high flow oxygen plus BiPAP would be the solution to the problem.
But if I give that answer in a different way, in an asthma patient, oxygenation is not the issue at the outset. The issue is the bronchoconstriction. You have to think in that way. So bronchodilation is the best way of getting the oxygenation.
Thank you.
Thank you.
So no further questions. We'll conclude the symposium.
Thank you very much.
Thank you very much.
That was a very interesting and accelerating discussion. Thank you to our moderators and our expert panelists. Can I please have Dr. Inuka Lanerolle to hand over the tokens of appreciation? Dr. Dilshan Priyankara. Dr. Aflah Sadikeen. Dr. Dushyantha Goonewardene. And Dr. Kaminda Wijenayaka. Thank you, sir.
Obstetric emergencies don't wait, and neither can we. Welcome to the second symposium of the day, High Stakes Obstetric Emergencies, Mastering Eclampsia. Our expert speakers have gathered here today from diverse disciplines to provide you with the key insights and practical approaches to mastering this high-risk scenario.
So, let's bring up on stage our esteemed panel of experts. First, we have Dr. Prabodhana Ranaweera, Senior Lecturer, Department of Obstetrics and Gynecology, Faculty of Medicine, University of Colombo, and Honorary Consultant Obstetrician and Gynecologist, Disoisa Hospital for Women, Colombo. He has a special interest in medical disorders complicating pregnancy, and he has he advocates making childbirth a positive experience with respectful maternity care. A lot of you probably know our next panelist. He is the ERC ALS Course Director of Sri Lanka and the Chair of the Resuscitation Council, College of Anesthesia. Dr. Mithrajee Premarathne, Consultant Anesthetist at Colombo North Teaching Hospital. Giving us the emergency physician's perspective in an obstetric patient, we have these two panelists. Dr. Harendra Hewapathirana, Consultant Emergency Physician, District General Hospital, Martale. He has expertise in resuscitation of critically ill adult and pediatric patients, including trauma care. Next, we have Dr. Chulanga Wickramasinghe, Consultant Emergency Physician at Teaching Hospital, Prabodhana. He is actively involved in training emergency life support and point-of-care ultrasound in the field of emergency medicine.
Helping us navigate through this session are our moderators, Dr. Nisanki Vitana and Dr. Leshara Buddhima, Senior Registrars in Emergency Medicine. Over to you, moderators.
Good morning, welcome to the second symposium. I'm Dr. Leshara and I have Nisanki with me. And so let's begin our discussion with our esteemed panelists. So we have got a 30-year-old female transferred from a divisional hospital. She had a brief generalized tonic-clonic seizure in the ambulance and she was a known epilepsy patient. This current seizure had the same semiology as her usual ones. She looked obese and the seizure seemed to have settled by the time of admission. Let's begin the discussion with Dr. Harendra. Could you tell us your approach to managing this patient?
Okay, so good morning everyone. So we have an exciting case today to discuss and it will be interesting more and more with the time. Okay, so we have a patient, lady who had a immediate seizure in a moving vehicle. So the patient has come to the ED now and patient should be triaged into category 1, and should come into the resuscitation bed. Okay, so our approach as an emergency physician is a team-based systematic approach. So our team has pre-allocated roles to ease the task, and our systematic approach is the universal ABCD approach. Okay, that means the airway, breathing, circulation, assessing the disability, and looking for the exposure. Okay. So starting with the airway, we are looking.
To give you the details, the airway was patent. The lungs were clear with a saturation of 98 on room air. The heart rate was 110 big tachycardic with a blood pressure of 180 over 110, and the GCS was 13 with the size 3 pupils slowly reactive. The capillary blood sugar was 180 milligram per deciliter. She was moving all 4 limbs. The reflexes were exaggerated. And the temperature was recorded 37 centigrade. With these details, could you tell us how you change your approach and what possible conditions you consider here?
Okay. So starting with the airway, even the patient is airway is patent, we should look for imminent threat for the airway. Like patient is in the post-ictal period and the GCS will be low. So there's an aspiration risk for this patient and maybe already aspirated. So we should supplement with the high flow oxygen, like 15 liters per minute, 100% oxygen. Okay. Then about the breathing, so we should look for the aspiration, features of aspiration and respiratory distress and the oxygenation. Coming into the circulation, so this patient has tachycardia and hypertension to begin with. So this may be the background, it may be the manifestation of background seizure activity, or we may be dealing with the hypertensive emergency. Okay, so at that point we need to establish a IV line, and we need to send some investigation, like starting with the full blood count, electrolytes, creatinines, liver function test, and especially the BPG. So, and point of care testing like urine HCG, looking for the proteinuria, looking for proteins, and toxicology screen. As well as if we have the focus, we should look for any other complications patient has developed.
Okay, Dr. Harendra, your nursing officer rushed to you with the news of positive urine HCG. In addition, there was no proteinuria and urine toxicology was negative. And the blood gas showed a pH of 7.22, PCO2 of 45, lactate of 12 with a bicarb of 16. Then we managed to gather more history from the patient's husband, who revealed that she came in with complaints of a severe headache and blurred vision that have been present for the past day. She has had 4 episodes of vomiting and pain in the right upper quadrant over the last 4 hours. There's no history of trauma or fever, and they deny any substance abuse. She has been compliant with her anti-epileptic medications and had been seizure-free for the past 3 years. She had a 7-month period of amenorrhea and no history of hypertension. So with this information, Dr. Harendra, how would you narrow down your differentials?
Okay, so now the case has been is now turned into a complex situation with the patient has lady has diagnosed with pregnancy. Okay, so, but she has a past history of epilepsy as well. In worldwide, the seizures in pregnancies, most of the time it's due to the epilepsy. But the fatal condition is due to eclampsia.
Okay. If you think this is eclampsia, is there anything else you would add to the management?
So, okay, even the patient seizures has been settled. So we have now think of eclampsia at this moment. If we diagnose the eclampsia as the seizure the patient got, we need to start magnesium sulfate. By starting the magnesium sulfate, at simultaneous I would like to get inform the obstetric team as well, and depending on the circumstance, I will inform the anesthetist and the neonatologist as well.
Thank you, Dr. Harendra. So we noted an interesting point. There was no proteinuria. So, Dr. Prabodhana, so without the presence of proteinuria, does that exclude the diagnosis of eclampsia?
Yeah, right. So I'll just give a bit of a preamble for this. Like now, any woman with a pregnancy, so if you all are in the A&E or in a ward, even sometimes the patient denying that she's pregnant in a surgical ward somewhere or a medical ward, anybody having a fit with a pregnancy, until proven otherwise, it should be treated as eclampsia, because that can kill a woman, right? So that is something, because once you understand the pathophysiology, the preeclampsia is not just like a fit. It's a hypertension or the preeclampsia, and having eclampsia is the worst case scenario, and it's a multi-organ disease in the body. So you have to treat it with respect. So the number one is to this is a good case, because when you have a epilepsy background, you'll always think during the pregnancy they don't take medicine, and there's a chance of, if you think about epilepsy and take it easy, that can kill the woman, right? So to answer your question, like proteinuria, in our early days, most of you from the medical student days, we are, you have hypertension. If you have proteinuria, it is preeclampsia. No proteinuria, gestational hypertension. That was our earlier diagnosis. But now in 2000, because this has been changed over the period, And in 2018, the new guideline, or the new ISHP, that is the international society who kind of make the norms of diagnosing and treatment of hypertension in pregnancy, they have categorized 3 type of hypertension after 20 weeks. So number 1 would be gestational hypertension, number 2 is what we call transient hypertension, and the other one is preeclampsia or eclampsia, either de novo or superimposed on chronic hypertension. So the current diagnosis of preeclampsia is actually gestational hypertension, which is you have to have hypertension developing in either, they can have one of the 3 criteria. Number 1 is proteinuria still. If proteinuria is not there, right, so then there can be other organ dysfunction, which is liver. It could be neurological, which is usually the eclampsia. So they can have hypertension and eclampsia. They can have hypertension, never liver derangement. They can have hypertension with hematological manifestation like thrombocytopenia or hemolysis, LDH going up, something like that. And also, it could be the last one, the categories, they can have evidence of uteroplacental insufficiency, which is they have hypertension and a very small baby. They can have hypertension with an abruption, but no proteinuria. All these are considered as preeclampsia.
Okay. So, Dr. Prabodhana, if the local hospital doctor knew this patient was pregnant and suspected preeclampsia, what would have been the best practice to prevent a seizure en route?
Right. So in the norms, after the what we call once you have diagnosed or you suspect eclampsia, the treatment or the prevention, treatment and control, the drug of choice is megsulfate, nothing else. And now most of the hospital will have cannula nowadays, right? I mean, it's very rare for a hospital not to have a cannula, but let's say you are in the ambulance, no cannula even, right? Let's say, oh, you are moving that it's difficult to put a cannula in. Megsulfate can be given IM. It's a rare thing to happen nowadays. I have not seen somebody had a IM, megsulfate for a long time. But if needed, you can give it to the upper quadrant of the buttocks, 5 grams. It comes in a 5 gram, vial, so you can get like 10. It comes at what we call depends on the time. Nowadays we have what we call 5 grams in 10 ml. So you just draw 5 ml and then you can give it to my. But I mean, it can be really painful. So unless it's eclampsia, having a fit, if you're giving it as a prophylactic thing, better to put it with lignocaine. And I have to be careful when you are giving lignocaine IM, because you should not inject into a vessel, then that's the end of the patient. So that you have to make sure that IM and then 1 gram, 5 grams given IM, and if you get another fit to the other buttock. So you can alternate every 4 hours. Right? But she should have given IM injection if the cannula is not there. But if the cannula is there, you can give a 4 gram slow bolus, which you say over 5 to 10 minutes is fine.
Okay. Sometimes we get worried to give megsulfate if the patient is anuric. So, Dr. Prabodhana, what is your take on that?
Right. So the problem is megsulfate is excreted from the body unchanged from urine. So if there is, and it has a very narrow therapeutic index, which means the toxicity level and the therapeutic level, the gap is very low. Now we are worried about megsulfate because it's a central nervous system depressant, so it can go into respiratory arrest, cardiac arrest and all. But, so when the kidneys are not working, the drug cannot be excreted, so they can become toxic very easily. But the bolus dose, it's a very, so we say very rare to get toxic effect. So you can give the bolus even there is no drop of urine. But continuation or the infusion is the one we need urine output, not because you have to have urine to have it, because it's excreted.
Thank you, Dr. Prabodhana, for that insight. Dr. Chulanga, so we found this information from the transfer form. The medical officer at the peripheral unit has identified the high blood pressure of 180 over 110 and had commenced slow release nifedipine 20 milligram as a stat dose. And do you think this management is appropriate?
Yes, thanks, Lashara. Now, first of all, if he didn't knew this was a pregnancy, of course, that treatment would be sort of redundant. But in this case now, because we see that it's a preeclampsia, And if you don't have any IV drugs, of course, you will go for oral medication. But as you look at this case, it's sort of a pre-eclampsia where you're impending eclampsia, and that's why she got a seizure on the way. In that case, my first option or the recommended would be to go for an IV medication, specifically because you need to control that blood pressure. But it doesn't necessarily mean that if your blood pressure is 140 over 90, you won't get a seizure. But yes, so our targets would be to get it down to about 160 over 105. So yeah, so in that case, my first option would be IV labetalol. Because we're comfortable with it, we have it in A&Es. Then you start with a dose of 20 milligrams and as a slow bolus, and then you can sort of go on to an infusion if you want to control it tight. Once you control it, you can cut down on your infusion and maintain the blood pressure below that level. Of course, if you don't have labetalol or if you need to go for a second one, IV hydrolysine is the option. But the problem with IV hydrolysine is you can rapidly crash your blood pressure, so you should make sure that you have a running saline bolus in once you start that IV hydrolysine. But we do understand, but peripheral hospitals might not have any IV medication, so you then need to go for your oral medication. If the patient can swallow it, yes, so just go for a oral nifedipine. You start with 20 milligrams, and you can even go up to 60 milligrams. It sort of works in about 30 minutes, I guess. Yeah. And if you have labetalol, again, that's also an option, 200 milligrams of labetalol. But I understand that labetalol is also not available in most of the, it's very expensive, so it's not available in most of the peripheral units. Yeah, so that would be what we would do. Yeah.
Okay. In the emergency department, we are very fond of GTN. In many hypertensive emergencies with resistant hypertension, we use GTN. So what's the place of GTN here in eclampsia or preeclampsia?
Yes. So what we do recommend is if the patient has acute heart failure with acute pulmonary edema, yes, you can go for GTN. We're very comfortable with GTN. But if you think purely of eclampsia without any heart failure features, probably labetalol or even nicardipine, which is not available with us, would be the best drug. But if you have any heart failure, yes, GTN would help.
Just to add about labetalol. So labetalol is the drug of choice now. It's an alpha blocker and a beta blocker working together. So the blood pressure drop is smooth. And we have to understand that this high blood pressure comes actually from the baby. It's a baby's way of protecting itself because there's a problem with the placenta. So the baby is getting less blood. It's like, when you're watering the garden, if the water is not coming enough, you squeeze the nozzle so that the water will have a high pressure. So that's what the baby is trying to do to get more blood. So labetalol will lower the blood pressure slowly, but you have to be careful when you're giving labetalol to exclude asthma. If they're having asthma, that can precipitate very bad asthma that can, because he's already sick, that's going to be a problem. The second drug is the one we have been using long as medical students is hydrolysine. The labetalol came to picture later. Now, as Chulanga said, you have to preload the patient. Now, the problem with preeclampsia is there is always fluid leakage. So when you sometimes treat, because most of the deaths has actually occurred by us rather than the eclampsia or other thing killing the patient. Most of the deaths related to eclampsia and preeclampsia is occurred because of fluid overload, because they can get pulmonary edema very quickly. So hydrolysine is a problem, but it's, as he said, it can crash the blood. So if we will love to get the blood pressure very low very quickly, but that will sometimes kill the baby, because that's the baby is trying to get the little blood, so the blood pressure dropping will have an effect on the baby. Second thing is now hydrolysine, as you said, to preload, so you have to be very careful when it's going and to monitor the patients having pulmonary edema. That's the other thing. Now most of the peripheral unit will have nifedipine, which now is also considered as a good choice, though it effect is not as good as other two IV drugs, but if you don't have a choice, but especially when the blood pressure is mildly elevated with eclampsia, we can try that. And it's important when you have this high blood pressure, that is something because the prognosis is due to the high systolic pressures. Because we have to remember this woman is absolutely fine, right? So no high blood pressure, and suddenly in few minutes they can have hyper. So their vessels are not designed like a patient who's on chronic hypertension, whose the because of the thickening of the vessels, they can withstand high pressure. But here, so our primary objective, so when you have a eclamptic fit and high blood pressure, both has to happen simultaneously. Preventing a fit, mag sulfate, and reducing the blood pressure in like both arms, what we say. One arm mag sulfate going, other arm we have to get the blood pressure down. Our target values would be 140, less than 140, but above 130, and diastolic 90, above 80 if possible. That's our target, because that to protect the baby actually. So the slower the blood pressure, like smoothly getting down, will have a good benefit for the baby, but depending on what you have to decide.
Thank you, Dr. Prabodhana, for that insightful talk. Here we have identified an unsafe inter-hospital transfer. Dr. Mithrajee, if you are to transfer a pre-eclamptic patient from a local hospital, are there any measures that you recommend ensuring patient safety?
Yeah, thank you. I think in good old days when we started our anesthetic career, that is 1996. So those days, magnesium was just emerging, and the facilities of having infusion pumps were not common. So those days, when we are transferring such patient, as Prabodhana said, one of the option would be giving IM mag sulfate intramuscularly to the buttocks and transfer the patient. So hopefully within 4 hours, you could transfer the patient to any reasonable tertiary care unit in Sri Lankan setting. But transferring any critically ill patient, not just this patient, should have certain fundamental approaches, right? One thing would be stabilizing the patient from the transferring in or the local hospital. Because initially, patient had features of preeclampsia, severe headache, and some visual disturbances and high blood pressure. Even though in this case scenario, those information came late at the emergency department, so definitely patient is having preeclampsia. As already mentioned, the magnesium loading dose should have been given, and infusion should be started, provided they have a infusion pump. Could be given in a burette set IV line, but then it depends on the controlling the drop rate, errors can be. So ideally infusion pump, but other option would be still you give the IV loading dose and give IM magnesium sulfate and transfer the patient to the tertiary care unit. But again, the communication is an issue. In Sri Lanka, in other developed countries, sometimes you just contact the hotline, then they look after the rest of the communication, especially in trauma scenario. But in Sri Lanka, you have to contact the trauma surgeon, then the ICU for the ICU bed, then the anesthetic, then they say contact the lab, this and that. So it's a bit of a challenge in Sri Lankan setup, but here they should communicate to the relevant obstetric unit who will be taken care of this patient, since patient probably coming through the emergency department, the emergency physician there. Then the other issue is oxygenation en route. Talk about left lateral tilt and lateral decubitus position because of the autocaval compression and well-being of the fetus. The other probably most important thing is, in Sri Lanka, the most junior person you can pick up will be sent with the patient, because en route, if there is a fit, it's a really challenging situation. You need expertise as well as manpower. So the preparation for the event, and you should have all emergency medication, and depending on the distance, technically, I would say someone is competent in handling airway, familiar with the emergency drugs, should accompany the patient. Thank you.
Thank you, sir. So, Dr. Chulanga, so something's very familiar to us. can you enlighten us on triaging in pregnancy and the challenges that are associated with the pregnancy triage?
Yes, thank you, Lashara. So, to start off with, in our country, the 4-category triage, we don't really have a maternal triage tool. We do have the pediatric and the mental health triage tools, but we don't practice a maternal triage tool. But when you look at the literature and the papers, and in some of the countries, they do have triage tools, because one is for emergency departments, and some countries, they directly stream obstetric patients to a OBS unit. So they do have different triage tools for those OBS admissions. But all the papers say, yes, having a triage tool is quite important. It has a benefit, and it's proven to be useful. Just some of the triage tools were just, I had a look at. So one was a Birmingham symptom-specific obstetric triage tool. There was another one called the obstetric triage acuity scale and the maternal fetal index. So what's different in the maternal triage is that if you go with the same parameters for the adults, because the mother would have different physiology or adaptations to that physiology. So the cutoff numbers are going to be different. So if you want to triage a patient, you'll probably end up under-triaging that patient. And the other thing is, it has to be more symptom-specific, because especially things like headache, like in this case, headaches, blurred vision, we are thinking of preeclampsia, and vaginal bleeding, abdominal pain. So all of these will you will think of emergency. So that will score higher in a triage scale. And the other thing is, you need to think about the baby. So again, you need to think about whether the baby is moving. And so you have to take all of that into account when you look at a triage for maternity. But it's going to be very challenging, because then you would need your triage officers to be very much trained in looking at obstetric patients. So that's probably the triage challenge that we have. But however you triage, once you get the patient, it's very important that you see your patient and assess and monitor that patient. So I think at that stage, you will come across the early warning scores specific for mothers. So I think that will be another good way that you might not miss patients who deteriorate rapidly.
So to talk about the maternal early obstetric warning, modified early obstetric warning system, Dr. Mithrajee, if you can talk a bit about it.
I think, as Chulanga said, the standard national early warning score meant for generally sick, deteriorating adult patient will not work. So if you just look at the hypertension, if systolic above 160, diastolic above 110, and obtundation, when patient is not alert, so it go into the red zone automatically. On top of that, they have added the vaginal discharge and pain also, because they may be in labor pain. So anyone having high pain score, whether it's due to pregnancy, renal colic, or heart attack, they will be given high triage. So here it's visually capturing that you have red zone numbers, so you follow the red path. But here overall what is important is the track and trigger systems are in place if you want to prevent deteriorating patient and prevent them end up in ICU. So one way to track in obstructive patient is using early warning score.
Just to add what Dr. Now we have two situations, right? One is an emergency, and then monitoring. So all these modified systems and all is actually for monitoring the patient, because which is done by the nurses. So if 2 ambers or 1 red, you have to escalate. That's what you're supposed to do. But when you come to acute stage, you like now, for instance, if the patient with the eclampsia coming, so number 1 is to manage the eclampsia, airway and all that. Then only we think about the baby later. Only one instance we have to act very quickly, which is an abruption. But if say the mother's blood pressure is 180, 110, that's the only time, because abruption can kill the mother as well. That is why we go to the theater very quickly. But in any other instances, mother's life first, so we have to establish, we have to save the mother, because sometimes we get calls, like somebody's having, come and see the baby. We don't want to see the baby. First, the mother should be stable enough for us to deliver a baby. The only time we break that principle is when there's an abruption, because she can go to DIC very quickly, where we take risk and our anesthetist team help us to get the blood, and we usually go for a GA then, sometimes no investigation, because we have only about 15-20 minutes to deliver the baby. So they are otherwise, and actually we do it not to save the baby. In another way, we are trying to save the mother. So that's number one. And once we all do that, then only we come into all this, charts to monitor the patient, because sometimes as doctors we won't be able to sit with somebody and see whether that patient deteriorates. So it's two different things. And if we try to do this in an emergency situation, we are in trouble.
Okay.
Yeah,
Thank you very much.
Further clarify for that, that is actually true. If you look at the Livoni score, suppose if someone presented with ischemic sounding chest pain, for pain, you might give a category 2 in triage, and early warning score may be 2 or 3. The escalation pathway for early warning score 3 is even not hourly monitoring. 4-hourly monitoring, but chest pain you cannot do that. So you have to manage acute situation separately in any presentation, and for the monitoring purpose and subsequent escalation, you empower the rest of the staff to monitor the patient using early warning scores.
Thank you very much, Dr. Prabodhana and Dr. Mithrajee, for that comprehensive account. So now the patient is having another convulsion. Dr. Harendra, how will you approach now?
Okay, so patient is on methsulfate infusion, I think, at this moment, 1 milligram per hour. So this will be a recurrent eclamptic seizure. So we need to give another bolus of 2 gram methsulfate, but before that we need to do another reassessment of this patient. So there are many causes that can critically ill patient can go into a seizure, because that again a reassessment from A to E, because this patient can have this seizure by the recurrent eclampsia or the complications that develop due to the eclampsia. Even that the patient has had a fit en route, we don't know what trauma has happened to this patient. Okay, so first we need to start methsulfate, then thorough reassessment, and actively looking for any complications. And if the fitting has not been stopped, we need to think about the second line of treatment.
Okay. So I will direct this question to Dr. Prabodhana. If the seizure doesn't settle with methsulfate, would you consider giving benzodiazepines, and is there a place for the second and third line medications as in status epilepticus pathway?
Yeah, so it's whatever available. So methsulfate is our drug of choice. After that, whatever, it can even go whatever is available, diazepam, lorazepam, whatever you have, because the more when you have the fit, what is GTC, patient is not breathing. So you have to there's no point putting oxygen, nothing, patient is not just breathing. And the more you stay, mother's life is danger, baby's life is danger, right? Though we consider the mother first, if we can stop. So it can even up to, we try all that, and if not, then the anesthetist team, you guys will take over and hopefully even do paralyzer intubation, I don't know. You have to stop the fit as quickly as possible. Now usually majority of the eclamptic fit will stop within 2 to 3 minutes. So at that time, you can't put her to left lateral, nothing. You just stop her getting injured, right? In a bed, you hold the patient, wait for 2 to 3 minutes, he subsides, then only check your airway and breathe, and you can actually, we always say in our emergencies, when we are training patients, we name the patient Mrs. Tilt. So you have to always remember that 30-degree tilt to the buttock. You just have to put a small cushion, because otherwise the gravid uterus after 20 weeks will compress the inferior vena cava. That will reduce the blood supply to the the heart, and cardiac output, everything goes down, and that may have an issue also. So you always have this tilt, and so to remind us, we always call the patient Mrs. Tilt. So remind that in our emergency. So the first thing, once you are doing that, once the patient recover from the fit, at that time you have to, and you can even put to left lateral, and after you check the airway and breathing, and then do it. But the important thing is to, stop, like if it is recurring, you give them second mag sulfate, not working, you have to give whatever the other medication that you will have, whatever available in the ward. If not, then the next step would be the paralysis and ventilation.
Thank you very much, Dr. Prabodhana, for that important take. So, Dr. Mithrajee, if the patient needs intubation in the emergency department, what would be your advice?
So, it's a challenging situation for two reasons. One thing, the locality itself, generally, I mean, yes, emergency departments are equipped for intubation, but it's a more challenging situation. Intubating in an eclamptic patient is further complicates the situation because it's sometimes could be an untested environment for this sort of scenario. As Prabodhana said, if despite of magnesium sulfate, especially when you have to go for 2 further boluses because of the recurrent pit, now almost we are up to 40 minutes into the scenario, and if it's like a multidisciplinary decision with POGs, anesthetists and emergency physicians. Probably you will take a team-based decision to go for, securing the airway. So generally we try to avoid intubation and GA if we plan for an operative delivery in a eclamptic patient. So where they maintain the saturation, they regain the consciousness after the fit, and even you could stabilize them for a couple of hours in HDU, ICU, and get to the theatre with the agreement of the VOGs in the presence of neonatologists, and go for a regional technique would be more acceptable, feasible and preferred method. But here you have to secure the airway as a semi-emergency. Then we need to prepare for difficult intubation and should have a rescue plan when we cannot intubate, cannot ventilate situation. So still the induction agent, we have few options. Thiopentone sodium, it's a time-tested medication, but unfortunately not in use for many years, and young anesthetists are not familiar. When we were started, that was the only induction agent we had those days. So thiopentone sodium is good, so we could tell the emergency guys to prepare these medications. So thiopentone, succinylmethonium, propofol, and also difficult intubation trolley, especially video laryngoscope, stilette and bougies, and tiltable bed, and additional manpower with a rescue plan. So other options like previous panel, whether you could move to a patient in a more controlled environment and do it, need to case by case decide whether you take the patient to the theatre, because after intubating you need to maintain the sedation. But I think here probably stabilization patient comes first, not the operative delivery. So it's a challenging situation.
Thank you, sir. So to our relief, our patient's seizures got settled, and this lady had 2 eclamptic seizures, currently on a magnesium sulfate infusion, and the blood pressure is controlled 150/90 with labetalol. So this is your area of expertise. Dr. Prabodhana, what do you do next with the mother and the baby?
So I just want to add this mag sulfate, then once in the second fit, we increase if the urine output is maintained to 2 grams per hour instead of 1 gram. So that's something you have to remember. And so once the patient's fit settles, so now it says the cure, because this is all done by the baby, so the cure would be delivery. So preeclampsia is cured by, and yes, of course, the first 24 to 48 hours is again critical, because it's all about cytokines released from the placenta, which causes all this endothelial damage and cause all this, the multi-organ, involvement, right? So brain is the last thing, like we are more severe problem. So once liver and above organs or evidence of liver and above organs are involved, the delivery, we prefer to deliver before the fit, but now let's say, yeah. So number one is we go and check whether the baby is alive. Then only we check the baby. So if you're trying to put CTGs and all that during the fates or when the initial resuscitation or initial management, you will see deceleration and all that, then you get panicking, right? So that's something you should not do, right? So once the patient is stable, either team or we all agree, okay, now she's fit enough to deliver, then we check, unless it's an abruption, we check the baby when the baby is alive. So if the baby is alive, then of course the next option would be deliver. We can, like after eclampsia, we try to deliver as quickly as possible, but I mean, like let's say neonatal facility not there, we have to think of lung maturity, so give, you know, steroids to, if the baby is surviving and the, you know, other mother's parameters are okay, she's not going to help syndrome or anything like that, then we can buy time and maybe till about 24 hours or the following day morning, where then neonatal team and everybody is ready, and the investigations are available and the mother is more favorable for a delivery, and then we decide and usually it's going to be a cesarean because it's a quicker way of delivery, but not always. Like if the cervix is favorable, now at 24 weeks it's unlikely, but if it is there, and of course if the baby is dead, then we just like it'll take some time, but then we don't need to rush anything, then it slowly the symptoms will come back to normal, then we think of delivery later. But if the baby is alive, yes, we need to deliver the baby quickly. Actually, we call it termination of pregnancy. It's not saving the baby. We are terminating pregnancy to save the mother, regardless of the period of gestation, whether it's 20 weeks, 37 weeks, 24 weeks. Once it happens, we deliver as quickly as possible.
Thank you very much, sir. So now it has been decided to send the patient directly to the theatre from the emergency department. Dr. Chulanga, before the disposition from the emergency department, would you consider brain imaging? If so, what are the indications to do a CT in this patient?
Yes. Well, first of all, if you're quite sure this is eclampsia, there's no point in spending time for a CT. You just have to put that patient on a CT trolley, and you're putting the patient at more risk as well. Especially if you get a CT in that CT machine, get a seizure while in the CT, it's going to be a bit devastating as well. But like we sort of went through some of the cases where you have refractory seizures, or you might have focal signs, where you might think of something intracranial like an ICH, which is shown on the picture. So if there's anything like that and it doesn't sort of fit into this eclamptic picture, I would definitely think of doing a CT. But otherwise, no, I would straight away go with the VOG's plan. And even if you do a CT and it's not, you might just see something like posterior ischemia or even cerebral edema. So that's probably the only thing you might see in an eclamptic patient, but otherwise, no.
And they say if you do a MRI after a fit, after a eclamptic fit, 90% will have some sort of a ICH, which is not clinically significant. So the only indication in obstetric point of view for a CT or a brain imaging would be if there's focal, there's residual symptoms after she's not waking up, or recurrent fits to exclude an ICH, where if the neurosurgeon thinks that they can save the baby.
Thank you, sir. So, Dr. Mithrajee, you are preparing the theatre for the delivery, and this patient is still in the A&E. Any important preoperative preparations you would expect A&E to carry out before sending this patient to the theatre?
I mean, if we have the basic lab investigation, or what we call a PET screen investigation, would be beneficial to decide on the mode of anesthesia, like full blood count. We look at the platelet count. If it is less than 50,000, then, I mean, preferably it should be 80,000 if we are going for a central neuraxis block. Then the INR, if it is above 1.5, again, regional neuraxial block is not preferred. So if you have very low platelet, then you need to have a CTG or thromboelastogram to guide us. So if these things can be arranged while we are managing the patient, that would be beneficial. So patient should be transferred with oxygen to the theatre. And in previous question, I forgot to tell you, when we are intubating a patient in A&E, one of the concern is to obtain the intubation response. With the intubation, so pressures can go up, and be ready to manage post-intubation hypotension. Because the medication we use for intubation, as well as they are intravascularly depleted even though they have leaky capillaries. So that also keep in mind. So basically, if patient is well controlled, magnesium is running, mode of choice would be go for a regional technique.
Thank you, sir. What if things don't go well and you face the worst shift of the year with a maternal cardiac arrest? Dr. Harendra, what might push this patient into cardiac arrest?
This will be the worst nightmare of an emergency physician in a shift. But I will be comfortable when the anesthetist and the obstetrician is on my arm's reach. Otherwise, I have to do their role as well. So, main reasons for this, if you think about this patient, hypoxia is the main killer. Okay, hypoxia, because the pregnancy have a low function residual capacity and less low safe period of apnea, they can easily go into hypoxia. And in this case, if the fits continues, that can have respiratory depression as well, and can cause aspiration can cause hypoxia as well, and the complication like pulmonary edema can cause hypoxia. So hypoxia is the main killer, but sometimes hypovolemia, like if the patient develop like placental abruption, where the bleeding has caused shock, this patient can get into cardiac arrest. There are many causes, but if you think about magnesium toxicity, to have a cardiac arrest, it should the level should be more than 20 milliequivalents per liter. So with this infusions, it won't happen.
Okay. So this is the worst case scenario we have to prepare for. So can you tell us the ALS modifications for a maternal cardiac arrest, Dr. Mithrajee?
Yeah, so basically the overall the PLS and ALS algorithm remains same, but there are certain modifications. One thing is early intubation for two reasons. One thing is the aspiration risk, and you need high inflation pressures to push oxygen because of the gravid uterus diaphragm push upwards. So early intubation you should consider, but otherwise normally we can go with LMA, and even after return of spontaneous circulation, when the expertise is available, you could consider intubation. So early intubation. And when you go through 4Hs and 4Ts, you should consider pregnancy specific Hs and Ts, like APH, patient can be hypovolemic due to obstructive hemorrhage or abruption placenta. Pulmonary embolism could be amniotic, real PE, like that. So you could have pregnancy specific Hs and Ts, but it's mostly supportive treatment, but you need to consider that. And especially after 20th week of gestation, if they go into cardiac arrest, the caval compression is an issue. So bimanual uterine displacement probably is more practical than tilting the patient and giving CPR. So someone else could maintain the bimanual displacement of the uterus and continue chest compressions. When it comes to defibrillation, if patients' fetal monitoring is on, you need to remove them before delivering the shock. I think that would be and the perimortem cesarean section. So after 4 minutes, by the 5th minute, baby should be delivered to save the mother. If it can be done at the site, the outcome shown to be better than if you push the patient to the theatre. So usually it's a bloodless field, because cardiac arrest situation, you can do a perimortem cesarean section. I think recently we had few incidents in Sri Lanka in Galle. They had successfully done perimortem cesarean section, but I think we have come long way. Now I think especially young obstetricians have no reservations for going it, but we had some challenges in the past to challenge that. And we had a very good life support course in collaboration with the College of Obstetricians and Anesthesiologists, immediate life support in obstetrics to cover all these emergencies, including maternal cardiac arrest. Unfortunately, this year we could not have any courses due to a variety of reasons. But it is rare, but it's challenging.
Thank you very much, sir. Fortunately, this patient didn't go into cardiac arrest. After 3 days of hospital stay, mother had a successful recovery and got discharged. And the baby was doing well in the premature baby unit. Mother's blood pressure on discharge was 130/85. So, Dr. Prabodhana, what is the chance of this patient coming back with another eclamptic fit during the postpartum period?
Right, so they now until 6 weeks the risk is there, but the first 24 to 48 hours is the highest risk, and they say like even the patients who did not develop eclampsia, the majority or 40% of the eclamptic fit have occurred in the postpartum first 24 hours. So two reasons. Number one, once you deliver, you reduce your monitoring. That's the main reason. And the second one is because of the fluid shift. Because 500 ml of the fluid will come back to the mother's system, where brain edema, pulmonary edema, and all that can happen. So the first 24 to 48 hours is very critical. So after that, the chances becomes low and low and low. But the recorded cases are there up to 42 days or postpartum period. So you have to be careful, and when you are discharging, what we call safety netting is very important to tell the patient if you develop any of those symptoms to come back immediately, headache, blurring of vision, nausea, vomiting, and to check the blood pressure at least every other day in the first couple of weeks.
So it comes to the end of our symposium. Huge thank you to the esteemed panelists for sharing your insights and experience today with us. And your perspectives were very incredibly valuable. Now we come, we don't have much time for the questions and answers, unfortunately.
Thank you very much for the interesting discussion. May I please invite Dr. Dushyantha Goonewardene up here on stage to hand over the tokens of appreciation to our panel of experts. Dr. Prabodhana Ranaweera, Dr. Mithrajee Premarathne, Dr. Harendra hewapathirana, Dr. Chulanga Wickramasinghe. Ladies and gentlemen, please give a big round of applause to our expert panel of speakers.
The small patients often bring some of the biggest challenges, and the approach to handling these challenges is unique. Therefore, our approach to this symposium will also be unique and dedicated to address the unique complexities of pediatric care.
Allow me to welcome the distinguished panel of speakers for this symposium. Dr. Thomas Georgeson, or Dr. Tom as we call him. He is a consultant emergency physician from the Canberra Hospital Emergency Department, Australia, who had been closely working with the Specialty Board of Emergency Medicine to enhance the quality of our emergency trainees. He has completed his pediatric emergency medicine subspecialty training and has co-authored several publications relating to pediatric emergency medicine. Sir, can you please come up on stage? We also have two pediatricians joining us today who I honestly can say are true experts, tirelessly dedicated to managing acutely ill children with diverse presentations. Dr. Michael Jans, consultant pediatrician, preliminary care unit, Lady Ridgeway Hospital for Children. Dear sir, can you please come up on stage? So, our next speaker, Dr. Viraj Jayasinghe, consultant pediatrician, National Institute of Infectious Diseases. And our final expert panelist is Dr. Dinesh Veerasinghe, Consultant Emergency Physician, Teaching Hospital, Anuradhapura.
And to moderate this session, we have a special guest, Senior Consultant Pediatrician, Dr. Srilal De Silva. To call him a guest would be wrong because he is no stranger to emergency medicine. He has played a vital role in the development of emergency medicine in Sri Lanka and is currently on a single-minded mission to improve the pre-hospital care in Sri Lanka as the Chief Medical Officer of the Swasariya Ambulance Service. Along with him, we have Dr. Prasanna Nadaraja, Consultant Emergency Physician, National Hospital of Sri Lanka. Over to you, sirs.
Okay, good morning. To start the symposium, we have Dr. Tom, and he's going to speak to us on vomiting and shock. I think it's over to Tom.
Good morning, everyone, and thank you very much for inviting me to speak here today. It's a great honour to be part of this symposium, and also a great honour to be sharing the podium with my esteemed colleagues who are so skilled and knowledgeable in paediatric emergency medicine. Thank you. Today we are going to talk about shock in its various forms, and in fact all of our 4 cases are going to relate to that. And I'm going to begin with a slightly different type of shock in young infants. We're hoping to offer you a variety of perspectives on this topic during this symposium. So let's begin with this patient, a real patient that we've experienced in our career. This was a 2-week-old infant who presented with vomiting and lethargy for 6 hours, who looked floppy and unwell, brought to our resuscitation area in Canberra Hospital, grunting, low saturations, and evident signs of cardiovascular shock. Also quite cold and with a low blood sugar level. Now, in our management, which, to be honest, is the standard management which I know, worldwide would be performed for this patient, we supported the airway, breathing, gave IV fluid boluses. We sent a blood gas which suggested that there was a quite significant lactic acidosis, and started some IV antibiotics. And we noticed that there was minimal improvement. This, no doubt, is a patient to which you're all familiar. It is the child or the infant in shock. Now, when we have worked over this case in our hospital and modelled it in various simulation scenarios with our teams, and these are teams of quite experienced doctors as well as junior doctors, most of the time what we find is that people are competent to do all of these things without any problems. And they will usually approach this point. And in the majority of cases, if you were to ask people what's their thinking at this stage, they would often indicate sepsis, which is not a bad thought. But the reason I am raising this case today is because we're looking at various aspects of the infant with shock, and this patient, in fact, is not sepsis. And when we ask our paediatric simulation teams what to do next, there is a tendency to get a little bit stuck. And I think I'm going to hope to explain to you how we can approach this, because this is, in fact, malrotation. What is malrotation? Now, I know some of you here are very experienced and some of you are still training, but I'm going to give a brief overview. There is a normal rotation of the gut during the embryonic period, a transition between 6 and 12 weeks, during which the small and part of the large bowel rotates into its adult or final human position. malrotation is the failure of this normal rotation. And what it does is it leads to an abnormally narrow mesenteric base for the small bowel and part of the large bowel. In fact, you could call it a ticking time bomb. And many of these patients are asymptomatic, but there is a risk at some stage of them having volvulus. And on this slide here, you can see how the risk is established. On the left, we have a normal rotational development in the embryonic period, and on the right, the malrotation. And the small dots represent the mesenteric attachment at the retroperitoneal space. And that mesenteric attachment in the normal patient on the left holds the bowel in a secure position and prevents it from rotating. But on the right-hand side, you can see the development of malrotation, where not only are the small bowel and the cecum in abnormal positions, but also what you have is the very small number of those dots, which represents a risk of twisting or volvulus. And that is the reason why these patients can become incredibly sick, often with very little warning. Malrotation does actually commonly occur in the neonatal period, if it does occur. It's not a common diagnosis, but it definitely, we would see a number each year. And big paediatric centres have been recorded to see up to sort of 5 to 10 cases a year. In fact, contrary to the case that I presented, it often occurs even within the first few days of life, but certainly the neonatal period is a period of high risk. And the classic case, which everyone is taught at med school and in their training, is to look for this bilious vomiting. But it's very important to realise that there are a large number of malrotation cases where you don't actually have bilious vomiting. And for example, in the case which I presented earlier, what you have instead is quite a large amount of shock as the primary presenting feature. And you may have accompanying abdominal distension or tenderness, but of course we know that in neonates, these things are quite difficult to elicit, and it makes the diagnosis very challenging. There's a number of ways that we can image, and most of the time, a plain abdominal film will be ordered. And here you have 2 plain abdominal films, and on the left-hand side, there are certainly suggestions there that there's a paucity of gas going through the small bowel, which suggests that there may in fact be an obstruction, or in the case of malrotation, a volvulus. But I have to also tell you that the right-hand side is a malrotation as well. And this is the challenge of the diagnosis, where you can be fooled by a plain abdominal film which suggests that there is gas in the larger part of the bowel. That being the case, the classic diagnosis, or the gold standard, which was established by a set of paediatric surgeons in Harvard back in the 1940s, was the use of an upper GI series. And that involves you putting contrast through an NG tube and looking for what's called this corkscrew sign, which you can see the arrow representing there. What about ultrasound? And of course, in emergency medicine, we're very fond of ultrasound, and it has the obvious advantages of being able to be brought to the bedside and is easier to perform in a very, very unwell patient. And ultrasound, there's actually a large body of literature about the use of ultrasound in malrotation over the last 10 or 15 years. On the left image here, you can see what's the normal anatomy on the ultrasound of some very important structures to diagnose malrotation. And in particular, it's the relationship of the superior mesenteric vein and artery, which are the V and A in this image, and their relationship to the different parts of the duodenum. But I should also tell you there's a lot of controversy in the diagnosis of malrotation with ultrasound as well. The right-hand side, you can see that there's a difference in those relationships between the A and the V, and then the distortion of the duodenal outline. And this is in fact malrotation. But it's a complex thing with a lot of evolving evidence, and I should say some controversy in the literature. Malrotation brings in the best elements of paediatric emergency medicine, because at this point, you really have to make a critical decision. If the gut is at risk and there's ongoing ischemia in a shocked patient, you really should be going to the operating theatre as soon as possible. But of course, no paediatric surgeon or anaesthetist is very keen on taking a shocked patient for open abdominal surgery if the diagnosis is unclear. And so here we bring our best skills to bear, which is to discuss with our colleagues, including the radiologists and the surgical team, about the way forward and whether any further imaging should be performed. But in our patient, certainly the emphasis was to go to theatre as soon as possible. And so then I come to, I guess, the most important part of all of this, which is that these symptoms, which you can see on the slide at the moment, are really the key symptoms of a shocked or unwell infant. And they look a lot like sepsis, but they can also be other things. And that's very important for us to note. And what we've experienced in the paediatric simulation environment in my own home setting is that these symptoms can obscure the fact that you need to be working harder at the examination component of your diagnosis. Because it's not always easy to pick up the clues of malrotation in this age group. You can use the feeding history. Certainly if the colour of the vomit is a particular type, then that can be leading. But sometimes that's not there. And so thinking about the pattern of onset of the illness, or in particular, examining the patient very carefully. Another surgical diagnosis which shares a similar sort of onset and severity can be an obstructed inguinal hernia, which also presents as a surgical emergency in the neonate. So I'll leave you with this thought as we continue with our cases on shock in young infants and in children, is that most shock in neonates and young infants actually is sepsis, and that's the majority of what you'll see. But you need to be mindful of these other potential diagnoses. And I think that what we have shown in our setting is that simulation is an excellent environment to train teams to recognise these components and also to do resuscitation and diagnosis at the same time. Thank you very much. I think we'll have questions later. Okay.
Thank you, Dr. Thomas, for that succinct description of how to diagnose and manage a patient malrotation. We'll take the questions in the end. Now I invite Dr. Michael to proceed in managing a patient with septic shock.
Thank you, Prasanna. So that was a very interesting talk by Tom. And so I'm going to talk about a patient with septic shock. So it's very good that Tom highlighted that that even though patient presents in shock, every shock is not a septic shock. So it's very important to identify what the cause is. So my patient is actual patient, a 13-year-old child who presented the PCU with a one-day history of fever, had severe headache and was drowsy and confused. And when we examined the patient, he was tachypneic, and the main problem was that the pulse rate was high. So tachycardia, moderate volume pulse, prolonged capillary filling time, and blood pressure was low, 80/40 with a white pulse pressure, and it's a low map obviously, and the GCS was low, GCS was 11, and there was marked neck stiffness. There was no rashes, but had very high fever. So here, because the neck stiffness was there and the high fever, it would probably reasonable to go for a diagnosis of a septic shock as child is in shock. But in our setup, we had to be very careful. We have a lot of dengue around as well. So even though we start the initial management with boluses, we should always reassess and see the cause of the shock. So actually this patient is a septic shock, so I'll be talking about septic shock, and child had features of meningitis as well. So when you're managing a patient with septic shock, there are a lot of challenges. This is especially because a lot of the research that has been done on managing septic shock is in adults, and we don't have really very high evidence in children. Most of that is taken from adult patients. And yeah, so there are a lot of difficulties. Most of it is adult or best practice. So when we manage this patient with septic shock, there are some issues in the management that we have trouble with. So the first thing is like recognizing the ill child in the triage in our emergency department. So what it has found is, what they recommend is in the literature, to have screening tools. So the screening tools are standard screening tools where we use pediatric early warning scores is found to be, was recommended. But we need to always reassess and see whether tools are actually detecting these patients and adjusting accordingly. So the tool that we will use will depend on the population, our hospital, and so there's no real standard one that's recommended. So it will change from depend on your units and your population. So this patient actually was detected by a pediatric early warning score and brought into the ETU immediately as a category 1 patient. So the next issue is vascular access. So it's very, very important that we get the access. So child in shock, we need to treat the shock quickly. So it's important to get the vascular access. So a lot of the literature says within 5 minutes to have some sort of access, either intraosseous or intravenous or intraosseous. So Dinesh will be talking about all of this. So he'll give a comprehensive lecture about the access and the difficulties we have in getting access in children. So, but mainly you have to get some access quickly. Next thing, we have to take cultures, but we should not delay antibiotics. So we should start antibiotics as soon as possible, at least within the first hour, and it should be empirical and broad spectrum. So if you can't get the cultures, if you can't get the blood, we should start the antibiotics as soon as possible. By 1 hour, we should start the antibiotics. This is found to be reduce the mortality in septic shock by starting the antibiotics quickly. So next question is the fluid boluses. So what is the fluid we are using? So again, very controversial. But when you look at the literature, ultimately it comes to what we are using all the time. So a normal saline, 0.9% saline. So that is the the cheapest and most available. And generally, any other fluids are not found to have much any further benefits. So we go for normal saline. So next question is how much the volume. So again, and we start with 10 ml per kg or 20 ml per kg. So no one really knows exactly. So all the research that I've gone through just says between 10 and 20 ml per kg. But what we tend to use is we give 10 ml per kg and reassess the patient. So if he needs more, we'll give in 10 ml aliquots, and it's probably safe for us because we have so much of dengue around as well. So in 10 ml per kg, and generally we can give between 40 and 60 ml per kg in the first hour, within 1 hour. So when we give in that dose, again the literature says, I'm going from mainly the pediatric preventing sepsis guidelines. So within 1 hour, if we have ICU settings, good ICU monitoring, we can go up to 60 ml per kg in the first hour. If you are not having good ICU settings, this recommend 40 ml per kg in the first hour. So remember that even though we say 40 or 60, we are always reassessing the patient. So if we are looking at the pulse rate, pulse volume, capillary filling times, blood pressure, and reassess it. So if we are getting our circulation back with less than 40, it's fine. But if not, we have to keep on repeating, but we are also reassessing for fluid overload. So if the child is getting features of overload, so bigger children, elevated JVP, hepatomegaly, basal Krebs, features of overload, we'll have to stop the fluids and start on inotropes quickly. But if we are going to come in close to 40 in a low resource setup, or even in a good resource setup like LRH, if we are coming close to 60, we should start inotropes. So which inotrope will she start is the next question. So generally in our setup, pediatrics, we are starting with adrenaline, and that is our main inotrope. So I think some question that asks, what about noradrenaline? If it's a warm shock, why not noradrenaline? So what has been found is in the research that you cannot differentiate cold shock from warm shock by clinical parameters. So what our interventions and advice, start the adrenaline unless you're really sure that it's a warm shock. So once we get to the ICU, when they start put in their lines and get their measurements, they can decide whether it's a warm shock or cold shock and decide on whether they change the inotropes. So monitoring tools, again, the monitoring of the patient is very important clinical. Like in the first lecture, sir said touch the patient. So see the pulse, very important, pulse rate, pulse volume, capillary film time, blood pressures, line of flow, urine output. So those parameters will decide on how much your fluid you need to get. And you have to keep on reassessing and see, and also look for features of overload. So we can monitor the response of the child clinically. Another important is to do the blood gas. So lactate levels to see, we are assessing is see whether the lactates are coming down. But there are certain researchers that are showing that even more than the lactate, our clinical assessment. Capillary fill time is even superior to the lactate levels as assessed in a level of level of shock. Okay, so we don't need central access to start inotropes. We need to start inotropes quickly if it's not responding to fluids. So we can start with peripheral lines. And use of steroids, another thing that's asked frequently by our registrars. So we don't start steroids unless the shock is, septic shock is you first do the fluid resuscitation, inotropes. If it's still not responding, it's resistant to inotropes as well, only you will consider steroids, and that also will be hydrocortisone. And particularly do it if you are suspecting adrenal insufficiency or especially a meningococcal infection. So important to do source removal. So in our case here, it was a meningitis, so we were not able to do that. Okay, so we have managed a patient with the ABC oxygen, and we have managed to get a cannula, and we have taken blood cultures and VBGs and other investigations, and we have gone with 0.9% saline boluses, and we have gone at 10 ml per kg boluses up to 40 ml per kg. And at that point, we detected in the ultrasound that there was some, that the IVC was quite full, so we have gone on to inotropes with that. And with the inotropes, actually the patient's condition was, the circulation began to settle. So we have started antibiotics. So our antibiotics in our national guideline is to start, it's undifferentiated cause for the septic shock, to start IV ceftriaxone and IV ceftriaxone or ceftriaxone along with aminoglycoside. So in our patient, ceftriaxone was a meningitis, yes, but we have started amikacin as well. And child was admitted to the ICU. Did not need ventilation, but was able to wean off inotropes once the shock settled. And in a couple of days, actually was much better and transferred to ward. Later treated, LP was positive and treated as meningitis, discharged without any complications. Okay. So I think we'll take questions at the end. So over to Viraj.
Thank you, Michael. So it's next one to be given by Dr. Viraj Wijenayaka, who is the pediatrician at National Infectious Hospital and previously at LRH. Okay, so Viraj.
Right. So good morning, everyone. So the discussion will be on approach to the ill neonate and infant. So we are talking about shock in this symposium. So most of the times, neonates and infants who are in shock will also appear to be very unwell or ill, right? So, so neonates, they are babies less than 28 days of age, and the infants are children, babies less than 1 year of age. So the problem in this age group is when you have a very unwell or an ill baby, their manifestations are very vague, right? So a baby with sepsis and unwell, or a baby who is having a cardiac issue, coming with a malrotation with shock, so they all present with the same sort of features like poor feeding, lethargy, reduced activity, but they lack localizing signs. So for an example, if you take an 8-year-old or a 10-year-old child who's coming with a pneumonia, most of the times the history will be like cough, fever, pleuritic chest pain, shortness of breath for a few days, and maybe when you examine there are crepitations, bronchial breathing, reduced air entry. So you can, localize the infection. So we know that it's a pneumonia, and you go ahead with specific treatment. But in a 2-month-old baby who's coming with the pneumonia, maybe just having poor feeding and lethargy. There may be no crepitations, no history of cough, not even a fever. Sometimes they might even be hypothermic. So that's the diagnostic challenge in this age group. But only problem is, if you miss the diagnosis, the underlying cause, as Tom mentioned earlier, like the baby coming with shock, we thought it's a septic shock, went on managing, but if it was a cardiac cause, you missed it, and it will be quite costly. It will lead to a catastrophe, right? So that's why it's very important to know what are the most, 5 most important diagnoses not to miss, the 5 main causes of an unwell baby or an infant, right? So that we can think in those lines when you have an unwell baby and come to a diagnosis and manage appropriately, right? So the main objectives would be to understand that babies below 1 year would present with very vague manifestations when they are ill, and that to learn what are the 5 most common causes not to miss in a very ill neonate or infant, right? So let's look at a case. So we had a baby a few months back, was 3 weeks old, quite ill, reduced activity and poor feeding, so very vague manifestations, but was found to be having shortness of breath. So on our primary survey, we found that he was dyspneic and was in shock. So as Tom said, so what we all do, airway was fine, so we applied oxygen, right, high flow, and then got in IV access, sent off the bloods. The bloods came as having a lactic acidosis, and then we started on fluid boluses, thinking lines of sepsis, which is the most common cause of shock in a baby of this age. But same with his case, my patient also didn't respond well to fluids. So then we were wondering, what could it be? Then on the secondary survey, we found that there was septomegaly. So we objectively looked for it, because one of the causes for a baby who comes very unwell in this age group would be a cardiogenic shock. So we looked for it, and then we found that there was septomegaly, which is the most consistent feature of a cardiogenic shock or heart failure in a baby below 1 year of age, right? So with that, we looked for murmurs. So unfortunately, there were no murmurs. Again, we were in a dilemma. Look for the femorals. Yes, the femorals are not palpable. So then that made our diagnosis much easier. So it's a coarctation, right? Then went on to the next step, did the pulse oximetry in the right upper limb and the lower limb, found out that there was a significant difference, right? So our clinical diagnosis was made. It was a preductor coarctation with a duct-dependent systemic circulation. So thereafter, of course, it was easy. Started prostaglandins, started on dobutamine, for which he responded very well and came out a shock. But still we covered for sepsis as well, right? So this is why it's very important for us to know what are the 5 main causes of a ill newborn or an infant, right? So these are the 5 big reasons, right? So one is infection. So that is sepsis, right? That's the first thing to think of. The next thing is cardiac, say with our patients. So could be septal defects, PDA, large VSD, or a duct-dependent systemic or a pulmonary circulation, or maybe obstructive lesion like a critical aortic stenosis, right? Then, of course, these babies who are small, they are susceptible to non-accidental injury. So injury is the third one, which you should not forget. And the other one, of course, surgical, what Tom has already discussed, right? Malrotations volvulus. Then, of course, metabolic causes, like because they are small babies, so there could be, there could be inborn error of metabolism that was not picked up earlier, right? So like a congenital adrenal hyperplasia coming with shock, right? Okay. So let's take a look, take one cause at a time and see. So sepsis, the commonest, so never to miss. So if you have especially a young infant, that's a baby below 3 months, coming with a high fever of about 38 degrees, always consider sepsis. But of course, some septic babies will be hypothermic, might not even mount a temperature, right? And other thing is, of course, the clinical manifestations are very vague. Poor feeding, lethargy, bulging fontanelle, irritability, shock, right? So in all these cases, cover for sepsis. Particularly if you're looking at a young infant below 3 months, ask for risk factors for sepsis like prematurity, premature rupture of membranes, maternal pyrexia, maternal UTI, right? And do a septic screen and start antibiotics immediately. Cardiac causes. So again, these babies will also come with poor feeding, lethargy, and poor activity. But the red flags would be, for you to think about a cardiac cause, would be poor feeding, head sweating, especially while feeding, and shortness of breath while feeding, and then cyanotic episodes. And of course, on examination, if there is a hepatomegaly, right, in an infant, always think about heart failure or cardiogenic shock. And of course, there will be respiratory distress, tachypnea, tachycardia, cyanosis, differential cyanosis, murmurs, and of course, a 4-limb blood pressure should be done in these patients, right? And especially if a patient is deteriorating with your fluid boluses who had come in shock, always think of cardiogenic shock, right? Chest X-ray and ECG would be helpful, and as well as a bedside ultrasound, right? Which will show you B lines, right? And then you can look at the cardiac contractility and look at the IVC. IVC will be full. So with a full IVC, if a baby comes in shock, think of cardiogenic shock or obstructive shock, right? So again, prostaglandins in a newborn, if you're thinking about a duct-dependent lesion, inotropes in cardiogenic shock, and always consider sepsis as well. So metabolic causes, there are many, right, like congenital adrenal hyperplasia, organic acidemias, right? So the red flags again would be, if there is unwell baby, if there is consanguinity, previous miscarriages, family history of sudden infant death syndrome, and also a known metabolic disorder running in the family, always think of this. And the manifestation again are very vague, and there'll be encephalopathic, drowsy, vomiting, seizures, right? And like a basic screening would be to do a CBS. Sugar will be low in certain conditions like fatty acid oxidation defects and congenital adrenal hyperplasia. If you do a gas, if there is acidosis, hyponatremia, and hyperkalemia, think of congenital adrenal hyperplasia. Do lactate levels, and ammonia will be high in urea cycle defects. Ketone bodies are also negative in fatty acid oxidation defects. So the basic management would be keep the nil by mouth, because most of the times these metabolic disorders involve protein or fatty acid metabolism. So you want to prevent gluconeogenesis, right? So you want to prevent protein breakdown. So start them on a 10% dextrose infusion to give them adequate calories so that they don't break down fat or protein, right? And get the metabolic team involved early. Non-accident injury, very important for you not to miss. Right. So if the history is very bizarre, inconsistent, vague, and unusual interaction between parents and children, and then the mechanism of injury not consistent with the developmental age, what they say is children who don't cruise, don't bruise. So like a 2-month-old baby coming with bruises, always think of this. And also remove their clothing properly and look for any evidence of bruising or injuries, right? So do the emergency management, get the safeguarding team involved early in these patients, right? Then, of course, surgical causes, Tom had already elaborated and discussed about it, malrotation, volvulus. Red flag signs would be any features of intestinal obstruction. So keep them nil by mouth, IV fluid resuscitation, IV antibiotics, then NG tube insertion, probably do an X-ray, which might give you a clue, right? And then early surgical consultation. So these are the take-home messages that I want you to remember. So one thing is, most ill neonates and infants, they present with very vague signs and symptoms, but don't miss the most important 5, right? So the big 5 would be sepsis, cardiac causes, injury, metabolic disorders, and surgical causes. And an initial blood workup would be a count, electrolytes, a gas, sugar, blood culture, and CRP. Okay, so thank you. So questions we'll take at the end of the session.
Thank you, Dr. Viraj. As everybody knows, the younger the child gets, everybody gets very frightened to manage the children, and there was a very good review on what to do. Now we go to Dr. Dinesh to discuss on which one is better, whether it's IO or go for ultrasound-guided IV access in a sick child. Thank you.
Thank you, Prasanth. Yeah, good afternoon, everybody, and maybe good morning. Yeah, so we all agree, caring for children in distress is not easy, and it's clearly challenging. So there are countless conditions we may have to do prompt actions, as well as many situations we have to be very skillful in our actions. So let's go through this scenario. And you are getting a 4-year-old girl in your emergency department. So mother states that she is not herself and seems lethargic. And she has had a fever and a cough for the last few days. And today she's not doing well. So nurse came to you, and child was directed to the resuscitation area straight away. And she's now upset, the nurse. So you go there and start your assessment, and she looks toxic, and capillary filling time high, and glaze stare, and high respiratory rate and tachypnea. And you start to resuscitate the child, and your possible management is septic shock. I would be cautious after listening to the previous lectures. But for this scenario, I will keep my diagnosis as septic shock at inception. Yeah. Yes. Despite our optimal vigilance, there are many, there are still several pitfalls waiting, may wait for you to stumble into it. So in this scenario, so luckily we got an IO access, but a quick access as well as an efficient access is a must, and because of the lack of access or inefficient access, you won't be able to delay or slow your management in this sick child, so which is very unacceptable. So in this particular condition, so you may start your resuscitation with your IO, but see the fluid resuscitation, enormous amount maybe, and antibiotics, so some supportive medication may be dextrose, irritants like dextrose, so bicarbonate, and vasoactive agents maybe need repeat blood sampling. So it's a challenge. So when you consider the peripheral intravenous catheterization in the emergency department or in any emergency scenario, so most common invasive procedure in the emergency department, but yeah, it's very basic, but it's a unique challenge when you come to the pediatric population. And the trials or the evidence says only half of first attempts are successful, and when you fail your first attempt, the stress, maybe the child or the parent, it's enormous again. And you have to try multiple attempts, and again now you are in stress. So significant difficulty with intravenous access are often poorly recognized. That's another thing. So you don't recognize this difficulty beforehand. And reason for these difficulties are multifactorial. This may be child related, or maybe the performer related, or maybe the situational. And sometimes it will tell you the gravity of the issue. And in some centers in developed countries, they have a specialized vascular access team. It's a multidisciplinary team. Consists of maybe interventional radiologist, anesthesiologist, intensivist, right? So maybe play therapist, right? So they form those kind of teams to address these issues. So when I go through the literature, so I found this interesting study which was done in Queensland, Australia, which is POCI study, prospective observational study in vascular access of kids in the emergency department. So they were trying to look into identify the difficult peripheral intravenous cannulation. So they were mainly concentrating not only the patient-related factors, but the performer-related as well as the situational factors. So yes, there are some tools at the moment which can predict the difficult peripheral intravenous access, but they are mainly concentrated on the patients, maybe the palpability or the visibility of vein, or the age of the child, or history of prematurity. Those are the areas they were concerning. So in this POCI study, they were highlighting the factors like care affected, or what's the parent, state of the parent. So tearful, if they are tearful or distressed, the difficulties are more. And if they have some sort of a positive gesture, again, the difficulties are less. So not only that, the number of caregivers present, and the noise, the situation, then the environmental noise. So if they are screaming and loud, then the difficulties they encounter are high. So they have considered these areas. And the performer related factors. So if they have a sort of a positive gesture or positive attitude towards peripheral cannulation, so they will perform without much difficulty. But if they have less than 50% confidence, then the difficulties are more. So likewise, they have noted few areas, but at the moment we can't see any sort of a guidelines or tool based on areas, these areas. So now what? So failed peripheral IV, what is the option? Is that IO, something else? So we all have to agree, no choice in resuscitation, mainly the cardiac arrest conditions or peri-arrest condition, we have to quickly go for IO. So the recommendation is within 90 seconds, you have to get an access. And the research, it says the repeated attempts of IV delay this IO access achievement. Usually the frequent time is more than 3 minutes. So it is less than the standard time. But when you consider the IO access and continuous fluid resuscitation with IO access, there are some complications. So availability of the needles, again, there are few needle types, the mechanical, the drill-driven needles and the mechanical needles. And in our setups, I think in my center, I use this blood needle. So I get a needle and try to do it manually. So in case the failure rate is high and the complications are high, so you won't be able to maintain that IO line for a long time. And the training, again, the hesitancy of the performer, if they don't, if they're not confident, which give rise to failure of IO access. And if the child is conscious, the pain, is a considerable amount of pain with the IO access. And inadequate flow rate. When you compare with the IV, so the flow rate is very low, and you have to pressurize your fluids to get a good flow rate. So again, especially when you resuscitate a polytrauma patient, if they bleed more than 150 milliliters per minute, so that means they are crashing and they are in massive hemorrhage. So when you do that pressurizing, it can lead into red cell hemolysis. So a lot of problems with this IO, mainly when you maintain the IO access. So then what's the answer? Is that the point of care ultrasound guided IV? So let's see. Yes, in adult population, it's proven and with evidence proven. So without hesitation, you go with your probe and you do your cannulation. In pediatric population also, there are evidence, but you don't practice that most of the time, especially in our setup, I would say. And it's feasible. I think with this dengue episode, we all have ultrasound machines in the pediatric wards and the emergency departments too, and this is feasible and readily available. And the higher success rate is the trial proven 98.9% success rate when you use the ultrasound machine. But problem is how confidently you handle the probe, so that's very subjective. And reduce the number of punctures. So again, it's very useful to avoid the second puncture, and it's faster. And satisfaction, so the satisfaction of the parent as well as the child. So you may use that as some sort of distraction method too. So you can direct them or distract them with the screen while you try to locate the main vein maybe, or when you are doing the interventions. So there are a lot of, especially avoiding complications, the arterial punctures and the other damage to the other structures. So those things you can avoid. So especially in predicted difficult cannulations, so IV is the best. That's the trial proven evidence. And let me share these two articles. The first article, which was published in Medscape, and it's a PubMed journal. So they didn't see any difference with the routine or the conventional peripheral cannulation and using the ultrasound. But they clearly indicate locating the vein before the procedure. So it's much higher when you use the ultrasound scan. So you can use that as a hybrid method. You using the ultrasound scan you locate the vein, and you may follow with the conventional peripheral cannulation. And the last paper, which was in the BMJ, so in UK, they have done a study in pediatric in pediatric wards, or involved in the pediatricians. So they are noticing the competency or the exposure of ultrasound in pediatricians are less. So because of that, they are not using the ultrasound in their practice. So what they did was they continuously taught them ultrasound for 1 year, then they reassess the same population, and which was shown very good results, and they were performing not only the peripheral cannulation and the other ultrasound related investigations and monitoring. So it's a very easy skill to learn when you consider the Dreyfus model of skill acquisition. So it's not difficult. So those are the evidence for ultrasound in peripheral cannulation. So take home message. So peripheral cannulation, especially in a sick child, is notoriously difficult, and without delay, you have to go for IO, no doubt about that. But problem comes when you maintain the IO and when you consider the complications of IO. So if you have your machine with you, and if you are confident enough, and if you have practice enough, so go for it, and the results are shown by the evidence.
Okay, so we have listened to the 4 experts on pediatric emergencies. So I'm sure they'll be happy to answer any questions, if you have any questions. No questions? So we will open up then. We'll ask Dr. Thomas. There's very often we get a bit confused where the demarcation between dehydration and shock in children. How can you explain? How do you find that this patient is dehydrated and this patient is in shock?
Thank you, sir. It is possible to start with that the two can overlap. And certainly, patients that are severely dehydrated, may in fact go into shock. But there's no doubt that there's a lot of literature suggesting that identification of degree of dehydration is a difficult task, and there's a lot of inter-rater or lack of inter-rater reliability between different clinicians when they assess patients with dehydration. And that overlaps then with this question of shock, I think, because we often find with our trainees and junior doctors that without the history being very adequate or very clear-cut, that there will be some confusion between severe dehydration and shock. What do we do? So you obviously here in Sri Lanka face a problem which we don't face, which is dengue. But in our community, we don't deal with that as much. And so I think you work towards the systematic examination, particularly along the lines of the sort of things which Dr. Viraj has spoken about. But we will presumptively treat with IV fluids and assess response. And unless it's quite severe dehydration, most patients with dehydration will respond relatively quickly to fluids, whereas those in true shock, we're dealing with a different setup. So I think the initial assessment is critical, but not always 100% reliable. And then the approach is pragmatic. And that's a kind of feature of a lot of emergency medicine, in that you start some treatment and then you watch the response.
Okay. Yeah, thank you.
I got a question for Dr. Michael. Since you work in a pediatric hospital, I think you'll be able to tell us more on this. What's your comfort level in starting an inotrope on a peripheral limb? Because I think that's what most people are afraid of.
Yeah, so like we're discussing the septic shock, so you have given adequate fluid, and there's no response, or if they find there's features of overload, we have to start the inotrope. It's important to start the inotrope, and what is found in the literature, you can start from a peripheral vein. If it's a good vein in the antecubital fossa, you might even be able to keep it for much longer. Even one in the dorsum, you can keep it. So don't be hesitant to start from peripheral vein. But remember that once you have resuscitated, you can go for the central later, but start from peripheral definitely.
Any other questions? Okay, we'll ask Dr. Dinesh, since he has spoke on IV access. In pediatrics, we very often use, we use cold light or the vein weavers to get the IV access. This was before ultrasound era, but still it's been used. Have you come across use of vein weavers to locate the veins in
Yes, sir. So, thank you for asking that question. The answer is yes. So, as I said, importantly, first of all, we have to, it's worth to identify, is this a difficult cannulation or not? So, there are tools, and as I said, with the situational assessment, you may first see, okay, this can be a difficult cannulation like that. Then you use your adjuncts, maybe the cord light, or maybe the sedation, or maybe the reassurance, or other play activities maybe, and ultrasound importantly. So the cord light, yes, it visualizes, it helps you to identify the vein, especially in small, very small children, and we are using that, and near infrared light, I think that's the light we use, and it is very effective.
Yeah, thank you. I think one of the challenges is when there's hypoperfusion, it's not going to be very useful because the reflection is not very good. So always you have to fall on your clinical skills in getting the vein. Any comments, Viraj, Michael?
Thank you, sir. That was actually an excellent presentation about IO versus ultrasound guided access. And I wouldn't mind just adding an additional comment. I mean, when you look at critically unwell children, and if you have experience with them, and if they present into the emergency department and someone puts an IO, it's almost invariable that within about 30 seconds of having the IO in and trying to push, say, an adrenaline into the patient, somebody says, let's get an IV immediately. And the reason for that is that basically the IO is, as Dr. Dinesh pointed out, so incapable of fulfilling all the different needs which we have in a really significant resuscitation with a different amount of fluids. So it was a really interesting presentation, and I think we all agree that IO is the first go-to within that period of time, 90 seconds. But where ultrasound is really valuable, and I think in our hospital we're developing a lot of skills in paediatric ultrasound in these scenarios, is that instead of having another 4 or 5 attempts to get a peripheral IV, we go straight to a reasonably deep vein. And they're the veins which you won't see on a cold light, and really they're often quite hard to find. So I think the future of ultrasound-guided cannulation in these scenarios is really to probably put an IO in immediately to give your immediate drugs like adrenaline, but then look to go straight to an ultrasound-guided cannula. We have the benefit of having some very paediatric-orientated probes. There's a thing called the hockey stick probe, which we use, for instance, which is specific to young infants. But even with just a normal linear probe, you can often identify something there which you wouldn't otherwise find. So that would be my thoughts on regard to that question.
Okay. Any other questions? Yeah, a few more minutes.
I got one for Dr. Viraj. Like I said, it's very frightening when you encounter a neonate. Would there be any difference when the baby is like a couple of hours or a couple of days old and let's say, I don't know, a week or two old? Will there be much difference in the clinical presentation and the management there?
It's like if it's a newborn, most of the times, as soon as the baby is born, until at least about 6 hours of age, we will not discharge the baby. In Sri Lanka, of course, it will take about 24 hours. So most of the, then we do a neonatal examination before we discharge. So, and now we have added this pre and post ductal saturation assessment also before we discharge. So most of the times, the neonatal team would troubleshoot most of the, life-threatening complications before we discharge them. But of course, within the metabolic disorders, especially, sometimes we tend to miss. Nowadays, actually, I don't know, even despite this volume, the pre-post ductal saturation has been assessed, still we keep on getting these sort of babies with duct-dependent systemic circulations. So, as I mentioned earlier, the initial newborn period is very crucial because, this is the highest time for them to manifest with infections because their immunity is quite low. And the other thing is, this is the best, at that point, they have a lot of congenital anomalies coming with various presentations. So those are the two things, the congenital problems and the infections. Those are the two that you need to worry about in a baby, especially in the first 28 days and in young infancy. So young infancy is the first 3 months because what they say is even sepsis, even a group B sepsis could manifest as late as 3 months, which is called late onset sepsis. So a mother having premature rupture of membranes might have a bearing even at the age of 2 months. So up to 3 months, you need to be a bit careful and look carefully for these congenital issues and infections.
Thank you.
Okay, any other questions? Okay, so finally I would like to share one of the experiences that happened in one of the hospitals. This basically combines the maternal and in one of the maternal patients, a pregnant lady who came with fetal distress and around 35 weeks. And it's an emergency, so it was sent to, seen by the doctor in the obstetric team, came to the emergency department and went for section, and patient collapsed 4 hours after surgery and obviously later on died. So what went wrong here is this patient had fever before admission, 3 days of fever, no fever on admission, and full blood count was taken before surgery, but it was not available at the time of surgery. So later on, the patient went into shock. The blood count showed dengue. Later count was low, PCB was high, and full blood white cell count is only. So the mistake I think we did here was that we didn't follow the full blood count before taking up for surgery. Obviously, patient was in fetal distress and then had to go for a section. So the things that we learned, I think dengue is common here in our country. So patient had got admitted during the diffusence phase when the temperature is down. So the doctor, house doctor, or the doctor in the emergency department failed to document that he'll get a history of fever and follow up with the full blood count. So it happens from time to time. It's a good learning thing. I think we need to be fairly open on these things so that we have to prevent, and also the post section monitoring is important. Okay, I think if there are no other questions, I think we can close the session. So thank you very much for participating in this session. So thank you very much, all the speakers.
A big thank you to the panel of speakers of the Symposium 3 for the wealth of information shared with us in such an interesting manner. The keynotes discussed today will surely help us when managing our small patients. Now, I would like to invite Dr. Kaminda Wijenayaka up on the stage to hand over the tokens of appreciation. Dr. Thomas Georgeson, Dr. Michael Jans, Dr. Viraj and Dr. Dinesh Veerasinghe. So, ladies and gentlemen, that brings us to the conclusion of the morning session. We hope it has been a stimulating and insightful day for all of you. We will now break for lunch. It will be served at the cinnamon lunch, which will be which will be on the right-hand side as you enter the main lobby at the ground floor. Ushers will direct you. We have many interesting topics lined up for you in the afternoon. So the session will begin promptly at 12:45. So we kindly request that you return to your seats by that time. Thank you and enjoy your lunch. The organizing committee and the emergency medicine consultants, senior registrars and registrars kindly remain in the hall for a group photograph. Thank you.